Hello and welcome to the 2020 ADAA Virtual Fall Forum, Anxiety and Worry in Youth. We invite you to tweet along with us by tagging @GotAnxiety and using the hashtag ADAA Fall Forum 2020. Today's presentation features Dr. Barbara Kamholz, Dr. Sandra Pimentel, Dr. Mona Potter, Dr. Ellie Leibowitz, Dr. Crystal Lewis, licensed clinical social worker Lynn Lyons, Dr. Jamie Miko, and Dr. John Walkup. My name is Vicki Spielman, and I am the Associate Director of Membership and Education at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's forum. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer's audio by default. If you would prefer to join over the phone, just select phone call in the audio panel and the dial-in information will be displayed. Please note this webinar is being recorded and will be available as an on-demand webinar within 24 hours. All attendees should ensure they remain muted unless directed otherwise for the entire presentation to avoid background noise and distractions. During the Q&A portion, some attendees may have the opportunity to ask their questions aloud. Those attendees will be instructed to unmute their microphones at the appropriate time. Please be aware there will be brief moments of silence during the transitions between our individual presenters and our panelists. We appreciate your understanding. During the forum, each individual speaker and our panel will be answering your questions. You will have the opportunity to submit text questions at any time of the presentations by typing your questions into the chat box of the control panel. We are monitoring these questions, and during the Q&A sessions, moderators may invite you to unmute yourself to ask your question. In order to be able to ask your question aloud, you must first give GoToTraining permission to access your microphone. If you see a red X through the camera icon on your URL menu bar on the right side, as shown in the included graphic, you must click here and select yes to give GoToTraining access. If called upon to unmute yourself, click on the microphone icon in your attendee interface shown in the second graphic. If unmuted, the icon will be green and the presenters and your fellow attendees will be able to hear you. Please provide your name and then ask your question. Once you have asked your question, please mute your microphone again. If you do not wish to ask your question aloud, please state text only in the chat with your question. Any questions not answered during the live webinar may be emailed to webinars@adaa.org, and ADAA will provide those questions to the participants. Your registration for the Fall Forum includes the opportunity for CE/CME credit. All professional level attendees will receive an email with a link shortly after the completion of this webinar. This link will include the webinar survey and post-test questions required to receive a CE/CME certificate. Please reach out to webinars@adaa.org if you do not receive this link. I would now like to introduce our moderator, Dr. Barbara Kamholz.
Hi, everybody. So thank you, Vicki, for that. I appreciate it, and welcome, everybody. I want to mention that I am stepping in for Dr. Luana Marquez. She is the president of ADAA, and unfortunately was struck ill this morning. I will mention not with a COVID-related illness, but we are all wishing her well and missing her today. She sends her apologies for not being here. So I want to welcome you all. Right now we are at 89 attendees all over the country of all different mental health disciplines, and I'm hoping some professionals outside of mental health as well. I want to welcome you all to our second annual ADAA Fall Forum. The topic this year is anxiety and worry in youth. And I want to thank a number of people before we get started. Certainly, we could not be doing any of this without Vicki Spielman and Sasha Sicard, two of our incredible staff at ADAA who will be running the technical details of this show today. I think we all know we couldn't be doing this as mental health folks without that. Also want to thank you all for being here. As I mentioned, this is our second annual forum. And I do want to go ahead and just introduce our two individual speakers for today. Those will be Dr. Sandy Pimentel and Dr. Mona Potter. I'll be introducing them a little bit more specifically immediately before their talks, but they will be our two individual speakers today. And then we will also be having a panel moderated by Dr. Jamie Micco. As Vicki already mentioned, you're welcome to put questions in the chat at any time. We really encourage you to. We want to make this as interactive as possible. One of the plus sides of all that is going on is the ability to have a lot of interaction far and wide in this way. So we really want to encourage that. And with that, I believe I am pausing for a moment for a tech transition. So I'll do that unless otherwise told to do. So I see that Sandy is up, and I will take a moment to embarrass her. Hi, Sandy, with her very long laundry list of achievements and current positions. I don't think she sleeps much, so we can talk about that for an area for improvement. Briefly, I can't possibly do her justice, but briefly, Dr. Sandra Pimentel is at Montefiore Health System in New York, where obviously she has been managing for many months now COVID and COVID-related challenges in the New York area. In her free time, she's chief of child and adolescent psychology, director of the Anxiety and Mood Disorders Program, associate director of psychology training, and associate professor in the Department of Psychiatry and Behavioral Sciences when she's not making the rest of us look bad. Sandy, I will pass it over to you. Thanks for being here.
Thank you so much, Barbara. I appreciate it. Good to see you in this weird way, and it's fun to, I see names popping up, many that I don't know, but some that I do. So shout out to the proverbial faces in the crowd. I want to thank the ADAA crew, one for just all of the prep that goes into something like this, and certainly in this format, and God bless the tech people, because Lord knows we are ever dependent on them, and thank you for making this as smooth as possible, to make this happen. Shout out of good health to Luana. Hope she is feeling better soon. I also want to thank ADAA for putting this topic, anxiety and youth, a topic near and dear to me, of course, and I know to many of you, certainly now, but even before all of the challenges we are facing. And I would pick every forum and every symposium talk to focus on anxiety and issues in youth if I could. It's so important and foundational to so many other things that seem to come later. So I am thankful for the invitation to be here with you all, hopeful that our tech runs as smoothly as possible, and let's get started. So I'm going to share my screen, and let's see if we can. You hear me okay? All right, are my slides showing?
Yes, your slides are showing perfectly.
Okay, thank you. I can't see anything but my slides, so flying blind a little bit is, the new version of these things. So again, my thank yous for this topic. We decided to focus on, will my child be permanently affected? Which are questions that many are getting from parents, patients, friends, associates themselves, and really this worry that now we are in, at least pandemically related, in the 7th, 8th month of what is happening, and really starting to feel the drag. Someone said to me yesterday, the slog of it, and significant worry about impacts on children, of course, and wondering if there will be permanent effects on youth, and focusing on anxious youth in particular. So we're going to hope to answer that today. I'll tell you, the short answer is, we don't know. I don't know. So thank you for coming to this talk. It was nice to have you. But we're going to do our best to sort of try to come together with answers with the best evidence that we have, and in taking a developmental approach to helping anxious youth and their caregivers meet the challenges of these times. There are always challenges, and we're going to try to focus on some of the challenges happening now. So we'll do our best to answer some of this question. Learning objectives, because we have to have them. We want to highlight some of the relevant research literatures that might help us answer these. We have a very robust literature, as you all know, on CBT for anxiety in youth trauma, resiliency. We're going to pick some highlights from there that might help us out. We're going to try to identify some of the specific pandemic challenges and a way to think about the disruptions in terms of developmental milestones, which will then guide some of our thinking on how to possibly address and stem some of the effects on perhaps long-term challenges. And then identify at least 3 specific strategies. We like to have specific objectives, right? At another time, we might have added 5 or 6. And, you know, in pandemic times, we want to limit our expectations. And we're going to shoot for at least 3. Hopefully, we'll get to more. And maybe that's one of the lessons in all of this, is that we want to modify and really think, you know, carefully about what everything just takes longer now, right? And so we want to be careful about what we are committing ourselves to. And so hopefully we'll get to at least 3. And I'll look forward to the Q&A later. Lucky for you, you're in for a day of fun with Dr. Potter and all the folks on the panel. So if I mess anything up, or if you have any questions after here, you have a very solid day ahead. I'm lucky that I get to go first, and then they can answer all the questions that I don't get to. So my disclosures, no financial disclosures, and for the purpose of the talk, but I did feel that I should let you know that I bought this t-shirt on Etsy a little bit ago. I'm excited to receive it. And you know, why anxiety in youth? I think you all know the answer, but I'm going to highlight the most important reasons, I think. Why are we talking about anxiety in youth? Why is this forum focusing on anxiety and worry in youth? Well, anxiety is the most common class of psychiatric illness in youth. We know that. There's some indication that some of the rates are going up. And if you look now, and we'll talk a little bit about this later, about some of the rise in the acute response and acute stress that youth and adults are experiencing. But in terms of anxiety disorders generally, we know they are the most common class of psychiatric illness. We know they are associated with a host of immediate and distal impairments. And if untreated, they can lead to sort of some long-term impairments leading into adulthood. So we know that there are significant functional impairments. We know that anxiety and major depressive disorder, if you look at the global burden of disease studies, that in terms of years lived with disability, years lost to disability, sorry about that, anxiety and major depressive disorder sort of rank in the top. And if you look at some of the World Health Organization regions, what we know that anxiety disorders can be, you know, among the top, even as high as 4th in developed countries with respect to non-fatal health loss. So there are some significant impacts and effects of anxiety immediately and then more long-term. We know that there's research indicating that anxiety can precede drug and alcohol dependence by up to 10 years. When I was at Temple University with Kendall, shout out to the Kendall siblings and cousins out there, some of my colleagues at the time did a follow-up study on the clinical trial that had preceded our time there. And they looked at kids who received CBT for anxiety, and what they found 7 years later, and they had an amazing response rate, by the way. I forget the exact number, but it was like 90% response rate of folks who answered and answered questions. And what they found is that these early youth maintain their gains, and they also exhibit, those who received CBT, evidence reduced risk of substance abuse, and this was 7 years later or so. So there's good evidence that treating it, you know, can have positive impacts down the road. We'll talk more about that in a bit. We know that anxiety is connected to premature mortality, you know, it's associated with higher rates of diabetes and asthma and COPD and other medical diseases. We know that anxiety is also associated with suicide. And we know that anxiety, much like other psychiatric illnesses, onset in childhood and adolescence. And we know that up to 75% of lifetime psychiatric illnesses emerge in emerging adulthood, so under 24, at the age of 24, again, pointing us in the direction of intervening. And this is why we're all here today, right? Because we know that anxiety in youth broadly, not even pandemically speaking, is important. We know that anxiety is normal in terms of development, and a reminder that we're going to try to use development to think about some of the challenges of today. There are normative fears that come across development, and you know, we see in infants loud noises, startle response, strangers. These are part of normative development that they transition through, and they're transient. And then we see in toddlerhood and preschool ages, you know, the boogeyman, imaginary creatures, fears of separation as they are heading off to daycare or preschool, perhaps fears of the dark. Who among us didn't run really, really fast to turn on the light in our grandparents' basement. I certainly did, and it's a family story that we tell, and sort of natural, normal fears, animals, and then entering school age, fears and worries, injury, safety, natural events, fears of death, again, aligning and some of the cognitive development that is happening, and understanding, for example, of death as a permanent state as opposed to a sleep-like state. So we know that these fears occur across development, and then of course pre-adolescence and adolescence, fears of health, academic performance, as these become more important, and of course, move towards social worries and anxieties. Again, all normative, all transient, and what we're going to focus on is thinking about development. I think this is one of the most important bits of good news. If we're thinking about, hey, will my child be permanently affected? What we know is that development is a lifelong process, and starting early and proceeding through. This ends at 4 years, but we know it continues, and there's great neuroscience data coming on, showing how neural development continues up into the 20s, even late 20s. And so we know that development broadly is a path, and there are milestones along the way and challenges along the way that occur over the course of a band of time, and when youth can meet certain challenges. We also know that certain environments can enrich, enhance development, and we know that certain environments are toxic and can delay or disrupt development. And thinking about some of the current challenges and how to think about helping anxious youth in particular, taking a developmental approach and understanding what are some of the developmental challenges that are being disrupted by lockdowns or virtual remote learning or in-person learning or the hybrid model or things like that. So coming to understand that appreciating development as a process, that things that are happening now.
Thank you. Have a nice day. Oh, thank you.
To be able to account for some of these challenges, and also trying to think about what environment are we in, to get an understanding about factors that might be relevant in considering long-term impact. So 15 years ago, you know this, I won't over-focus, but what we know is there are various areas of development that occur normatively, from emotional, physical, cognitive, and language. Those tend to be the main focus, but there are also things that go on in terms of kids and creativity and cultural identity, morality, gender identity, attachment, where these areas, again, when we're thinking about how will this affect my child, we don't want it to be this global worry, trying to think about, okay, well, how is it affecting physically or socio-emotionally or in terms of creativity? We're seeing some challenges certainly for areas of development, and we'll talk about these, and we're also seeing opportunities for enhancement of creativity, for example, or morality in terms of considerations of right and wrong and altruism and things like that. So while there are and may be some disruptions, we're seeing as well some opportunities to impact development in different ways that may not have otherwise been. When we think about youth anxiety disorders, I mentioned this before, and I want to jump in a little bit, and this is a great paper, and there are a few out there that looked at functional impairment in youth, Anna Swan and Phil Kendall, and they really took a look not only on, the interesting thing about this one is that they looked at not only the impact of anxiety on these functional areas, and this slide does it no justice in terms of the comprehensiveness of it, they also looked at the potential impacts of treatment on functional improvements, beyond sort of some of the symptom presentations that we're seeing. And we're going to focus again on a little bit here for the purposes of our talk, where really, when we look at youth anxiety disorders, the general, what the research is telling us generally is that there are social impacts of youth anxiety that sort of, if you look at peer relationships, youth with anxiety disorders tend to have more problems in making friends, some likability issues, social competence and social skills, particularly if you look at social anxiety and some of the impacts there. We know that functionally as well, you start to see educational impairments. So if we think about some aspects of importance, we know can be enhanced by anxiety, having an anxiety disorder, and there's a certain there's a certain advantage to having perfectionism up to a point. And we also know, think about the perfectionist kid who gets so stuck, who then procrastinates and then doesn't turn the assignment. And so at the higher levels of those, how those then tend to affect performance and achievement. Thinking about your socially anxious patients and thinking about their fear and avoidance hierarchies or their exposure targets. How many times do you have on there, raise your hand in class or ask the teacher a question? So we see how youth anxiety can impact, and the avoidance associated with anxiety in particular can then affect educational and occupational performance. I have a promotion that would have given, I believe it was $10,000, because it required a lifelong history of social anxiety and some other things. And he turned down a job that would have given him a raise and a promotion because he didn't want to be in a role where he had to speak and present more, and that would have been a requirement of the job. So we start to see these educational and occupational impairments as a result of anxiety, and that the associated aspects of anxiety, and of course comorbidities sort of will complicate these things. And then of course we know that the role of family functioning, parental caregiver accommodation, family distress, increased family distress, ability to cope independently. We'll see this with emerging adults, and we'll talk a little bit about this in terms of assessing some of the transitions to adulthood. And then relationship quality in the family is associated in cases of youth with anxiety disorders with poorer relationship quality. And then there's some studies that show that life satisfaction overall can be affected, not surprisingly, by having an anxiety disorder and whatnot. And so we can see sort of across these areas functional impairments that we'll want to keep in mind as we're thinking about treating youth anxiety during these times. And so will there be long-term impacts on my child? Well, let's think about it socially, socio-emotionally, educationally, occupationally, in terms of family and the family functioning, really trying to hone in and be as specific as possible, because we know that there's a vulnerability there. We know that there's a vulnerability because of the presence of the anxiety disorder. And these are some of the questions that we're starting to see that sort of prompted the specific nature of this talk. So will the pandemic socially stunt my kid? So how will masks, social distancing, lack of interaction with other children affect kids' social and emotional development? This just came out, I believe, last week. Generation agoraphobia, fears that parents have if avoidance and not going outside or outdoors is going to have lasting mental harm now that these are stretching out. And what we're thinking about is how do we help consider these questions. And it's understandable if you think about the functional impairments we talked about and all the changes to our daily lives in the past 7 months, whatever it is now, 7 months or so. How are they going to have impacts on both the adults and especially, of course, the children and anxious youth if they are already vulnerable? And thinking about having to sort of reemerge to go outdoors, or increasing access to the outdoors, or some kids who are back in school or in a hybrid model. We'll talk a little bit about how to tailor some of our treatments based on the best evidence we have to addressing some of these. And we do want to be mindful because for many kids, we are hearing a reluctance to go outside or resume perhaps quote normal activities. And by the way, nothing is normal. One of my favorite tweets, because I exist on Twitter now because we have to, I suppose, and one of my favorite tweets was from a professor. She was on August 27th, I believe, and she was about to teach her first day, and her first slide said, nothing is normal, everything is still hard, or something to that effect. And I feel like everything should start with that premise that though we are trying these things and we keep talking about a new normal, this is not normal. And so understanding how these aspects and the worry that parents have, can then inform some of our considerations for intervention. And here's the other side, is that how can it also create adaptive patterns. So if we're looking at what were the behaviors before lockdown, before lockdowns that may be coming again, how can we help families, especially anxious youth, create adaptive patterns of behavior? So if there is doing what we know as best we can with the principles that we have, so thinking about gradual reemergence, for example. And I'm going to try to breeze through. We know these numbers have increased since last I sort of snipped this. There's real danger, right? There's real danger with COVID if we're thinking about COVID, and we know in particular that COVID-19 has affected people of color at twice the rate that it's affected white folks. And thinking about, I work in the Bronx, and that the mortality rate was higher in our populations. And so answering that question again, will there be long-term impacts for kids? It's important to know the communities that you work in, obviously, and understanding that for some youth, and especially youth of color, there's likely a higher risk of having these longer-term impacts. You know, as we get more data, and we'll share some of these data in a bit, knowing that that is disproportionately revealing what we knew to exist before in terms of determinants of health and health disparities and whatnot. We have to take into account the disproportionate impact on our families of color. And one of the other places that we saw impacts already was in food and financial insecurity, which is ongoing. It's not that we saw it and it's over. This is a picture from a food line in Texas. This was during the pandemic and during the earlier days of the pandemic. And we were hearing, even anecdotally in our families in the Bronx, that there was a lot of food insecurity. They weren't sure what to do. And thinking about the impacts financially in terms of financial insecurity, this is a study out of the UK that just came out, and I'll reference this a little bit from the NHS, that children aged 5 to 16 with a probable mental disorder were more than twice as likely to live in a household that had fallen behind with payments than children who were unlikely to have a mental disorder. And I'll talk a little bit more about this study in a couple of slides, but I wanted to highlight it here. And so if we're looking at risk and protective factors, at least coming out of the early research that we're seeing, again, these are early results, and thinking about how food and financial insecurity is impacting mental health. There's a long and robust literature on the relationship between economic disparities and mental health and health in general, for that matter. And COVID put that on blast. And so to see the effects and impacts on food and financial insecurity, and we also know that a study that just came out of the Department of Labor looking at worries in the job force, and not surprisingly, Black and Hispanic adults were reporting more worries about making payments, getting a job, finding a job, paying their mortgages and things like that. So coupled with all of these things, we can see where in these households in particular, there might be more vulnerability to mental health effects and anxiety and stress in particular. And this speaks to, and we can talk as much or as little about this, one, our role as interventionists and therapists and clinicians and supervisors, and the other is our role as advocates and thinking about how do we advocate for our families in ways that we get them the food and financial security that they need. And those are more systemic and systematic in nature. And so beyond the traditional anxiety disorder, really answering some of these disparities that sort of seem to lay foundation for many, many kids and families. So I'm not going to show, in the interest of time, I'm not going to show this video, but I highly encourage you to take a look. These are pandemic kids. This was from April in the Atlantic. And this video essentially asks kids what they think about COVID-19 and the pandemic and what they're thinking about. And a couple of things I want to highlight. One is they are worrying about what we were worried about and are worrying about. And we could play this video now and it would still ring true. They're worried about getting sick and loved ones getting sick. The young girl on the right talks about her additional worry because she has asthma, and she heard that having a pre-existing condition worsens the chances of being harmed by COVID-19. It talks about feeling nervous and other things, and they're worried about school and friends and family. And so not surprising what the kids are worried about. I will say, never underestimate kids, right? And the young girl on the left talks about how even though all of this is going on, it's remarkable that she's getting to live through a time that's likely going to be in the history books or something to that effect. And so I encourage you guys to take a look, and this is sort of a placeholder to remind us, that one, the worries that kids have will often mimic those that we have, and thinking about sort of what are the normative worries that all kids may have. And we know that kids with anxiety disorders tend to have those just with or enduring frequency and an inability to sort of be able to move past or let go of some of those worries. So being mindful of that in particular, as well as the capacity for kids to sort of have these thoughts about living in history. There's another kid in here, he's hilarious. He talks about, well, hey, we got to take care of this because we're the next adults, and so, I encourage you all to take a look at this video. And what we know is that there are increasing rates of COVID-19 in kids. This is a graphic from August. Thankfully, children have very low proportions of death from COVID-19, but we also know that they can be spreaders. And with schools opening and the variations of models being considered, whether it's grammar schools, elementary schools, or many of the colleges and college campuses and things like that, being mindful of that, COVID-19 still does affect children, and perhaps more importantly, that worry about getting others sick can be a very real worry, particularly if they live with someone who is vulnerable. And this is bearing out in some of the early research as well, coming out of other countries. So what do we know? We know in terms of the acute response from, if you're looking at studies coming out of Italy and China and other places, that there is an immediate psychological impact, unsurprisingly, of COVID-19, and there's increasing rates of reported stress, difficulty sleeping, things like that, and higher rates of stress are associated with having someone in the home or someone in the family having had COVID-19, having a history of a medical condition, and stress also is related to higher rates of stress as a result. Something that's protective is financial stability. So in families where there was more financial security, that was a protective factor. Again, nothing surprising here. And to the extent that the study of college students looked, they found increasing rates of anxiety related to the impact in daily life and how disrupted daily lives were and academic lives were impacted. So again, just some early considerations. This is the study I referenced before coming out of the UK that found that the lockdown made life worse for 2 in 5 children. So 40% of kids are saying that the lockdown made their life worse, and focusing on their anxieties, they were missing school, again, not surprising, family and friends contracting COVID. So this real worry from the real danger of having a family member get ill. The interesting thing about this study is this is a systematic study put out by NHS, and this was a follow-up from a 2017 survey, and they found that the rate of probable mental disorder in kids, I believe it was 5 to 22, went up from the first wave of the study to this now second wave of the study, and I believe it was 10% to about 16% in terms of likelihood of probable mental disorder. And they have a bunch of different findings. I'll highlight through a few as we go through our slides. And one of the most important ones, for example, is looking at rates of sleep disruption. And again, not surprisingly, we know that sleep was largely affected. And if you look at youth with probable mental disorder, again, based on the definition in this study, that they were more likely to report, I believe it was 60-something% report having significant sleep disruption. And if they looked at the age bands, what they found, and this is not surprising, that the highest rates of sleep disruption were between the ages of 17 and 22. Again, so important information in terms of thinking about how we need to sort of do what we already do and thinking about sleep and sleep hygiene and routines and whatnot. And on the other side, this study also revealed that a fairly large number of youth were reporting having supportive school environments and social environments. So again, being mindful that in terms of looking at, again, these longer term impacts, what are some of the areas of having these social supports, having the school be supportive? When the school was supportive, there was a lower report of anxiety. So again, thinking about how we can maximize what we essentially already know. And this is another study out of Australia from the University of Queensland, and they looked at anxiety and depression in kids. Again, to be a survey, I believe it was about 800 youth and families were surveyed. This came out last, or I guess 2 weeks ago now, and nearly 1 in 5 kids, so in their survey, about 20% were reporting significant disturbance with respect to anxiety and sleep and mood changes and some behavioral disruptions. And by and large, they found that many of the kids were actually quite resilient, sort of after having had the survey. And there was a small proportion of kids who seemed to be struggling the most. And again, this will not surprise you. So these were the kids who had a history of trauma related specifically to things, again, for them, like the bushfires. And if they had experienced through natural disasters, they were reporting higher rates of distress as they measured it. And in addition to, they also found that kids who were struggling, again, not surprisingly, had fewer areas of fewer social supports. And so again, a lot of the stuff that we already know. So thinking about the long-term impacts, how do we get, we target some of our work perhaps for kids who are more vulnerable in terms of prior trauma. How do we target growing and developing social supports and whatnot? And here's something that I want to point out. We'll talk about emerging adults in a little bit. And the arrow is pointing to the age group 18 to 24. This came out of the CDC study. This came out, I believe it was the end of June, and it found that looking at considering suicide in the past month, so in the past 30 days, 25% of 18 to 24-year-olds were reported. So that's 1 in 4 of our young adults are reporting seriously considering suicide in the past 30 days. So again, harkening back to what we already know and what we already do is of course, who is at risk for some of these thoughts, and doing more safety planning and doing what we need to do around that, and who this is a general sample. So who are these young adults who are really struggling and seriously considering suicide, and of course asking and safety planning and doing what we typically would do. What are parents worrying about? Not surprising. This is again connected to our talk. Parents are worried about the long-term impacts on children. So 70% of parents, and this is the stress in the time of COVID. The APA, our APA, American Psychological, does stress in the time of stress in America. Generally, they do these regular surveys, and they have adapted it to include stress in the time of COVID-19. And this was their results from June 2020, looking at what parents are stressing about and what they're worried about. And on the other side, holding it is that more than 4 in 5 parents, 80%, were saying that they were grateful for having additional time with their children at home and getting to do certain things that they perhaps would not have done. Another study, there are a bunch of these studies coming out. One came out, if you look at other portion of this study and a study that came out of Canada, not surprisingly, parents are also worried about how to manage their child's behaviors, increased acting out, anxiety, and things like that. And they are very anxious about balancing their own work and childcare and things like that. And you don't need me to tell you that. You don't need a survey to tell you that. If we talk to anyone who's a parent, particularly of a school-age child, they are struggling. And there was just something that was released today that was looking at the mothers exiting the workforce and not participating in the workforce as a result of bearing a lot of the burden of childcare, remote learning, and being at home for caregiving purposes. And so there's immense stress in our parents. And looking at sort of the immediate psychological effects, this again going back to Italy and Spain of the quarantine. I don't need to get onto the results of this, but there was a very, very high correlation, not surprising, between primary caregiver stress levels and those of their children. So looking at the stress level in parents, again, in terms of understanding any potential longer term effects and wanting to make sure that we pay attention to those. So back to our considerations of youth anxiety disorders and what the changes have been over these past months in terms of quarantine, social isolation, masks, anti-science messaging. See my purchase of my t-shirt, health risks, real health risks, death of loved ones and family members, grief and loss, family isolation, economic impact. This is a broad array of potential impacts and disruptions. Of course, when we're considering, again, going back to our developmental understanding and trying to understand what are some of the developmental specific impacts, depending on how old kids are and where they are on that path in terms of their development and the developmental tasks of that particular age range or developmental period, for example. And we know, again, another study looking at youth, that they're reporting that is making, like the NHS study, it's having a real impact on their health and mental health. 83% of young respondents in the Young Minds study, these were slightly older kids who have pre-existing conditions, were saying that 83% of them are saying that it's making it worse because of school closures, because of loss of routine and restricted social connections. So we know all of these things are happening, at least acutely. How can we now intervene and do what we need to do to address them as best we can? And the other thing that we know is that there are these disruptions, and there are, as I said before, additional opportunities perhaps to, that are coming from whether it's quarantine or wearing a mask or, some of the impacts that are happening, and being mindful as much of those. We know that our whole delivery care as mental health providers was upended and disrupted, and made some things happen in terms of offering telehealth that ultimately, I hope, will be positive. And certainly at our clinic, what we saw is our attendance and compliance with treatment has increased and improved. I run a social anxiety group, a CBT social anxiety group, and attendance was never better. It was in March, and it took us a little bit to coordinate and get it happening. And yes, there were 7 dark screens for the first couple of weeks, but little by little we got, you know, our socially anxious teenagers to show their forehead and then their face, then turn the lights on in the room and doing the exposures that we do. And they came every week, and they voted unanimously. Never happened. They voted unanimously to continue a maintenance group into the summer. So there were these ongoing effects and certainly disruptions to treatment, but also perhaps increasing access for many that may serve us ultimately well. So considering those in terms of when we are treating youth with anxiety in particular. So what do we do, right? We know that we have great evidence, I'll get to that in a second, in terms of CBT being effective, and we know that we are principle driven. Dating back to, shameless plug, I love Mary Cover Jones. I hope everyone, if you take nothing else from this talk, remember the name Mary Cover Jones. She is the mother of behavior therapy, and you know, based on her work and moving all the way into, this is a review from Kendall and Peterman, and it looks at all the different variations of CBT, individual, group, family, and the reported remission, you know, rates and the efficacy of these interventions. And I'll just briefly mention CAMS and CAMELS for those who don't know. And I believe Dr. Potter will talk a little bit more about both of these studies, as well. You know, Dr. Walkup is on, and all the folks on the panel can speak to this too. So the CAMS trial was the largest randomized clinical trial looking at CAMS, child and adolescent anxiety multimodal study, and it looked at, you know, four interventions: CBT alone, sertraline alone, the combined of the two, and a placebo arm. And you know, if you consider the acute results after 12 weeks of these treatments, what was found is that, you know, there were 3 effective treatments for anxiety: individual, the monotherapies, which were fairly equal, so the CBT and the sertraline, and then the combined treatment outperformed both. And so those were at the acute trial, very stringent criteria actually in terms of that. And then CAMELS, which was an extended long-term follow-up of the CAMS sample. And there were several points to come out of CAMELS, and I'll focus on a couple again for the purposes of our discussion today, and considering, you know, what are the potential long-term impacts of everything going on now on youth with anxiety disorders, and how do we potentially intervene? So a subset, about 22% of kids who responded well and early to the CBT continued, or to the trial, you know, continued to do well, which is good to hear. And it may have been protective for them with respect to, you know, chronic illness. So if they responded early and did well, they continue to do well. And then the one that I really want to, and there's a subset, about 30%, who were chronically ill, chronically anxious. And there's a subset of about, you know, 48% or so who relapsed. And who are those kids, and understanding what might lead youth to relapse, and some of those considerations for thinking about how we intervene, which I'll get to in a second. And I think CAMELS in particular speaks to the chronic, you know, nature of anxiety disorders in kids, and again, thinking about it through development and how we tweak our interventions. And you know, it's not just, you know, the 12 weeks or, you know, the sort of short-term intervention, and thinking perhaps on a broader view of ongoing, you know, mental health care, and how we think about offering mental health care to kids who have anxiety disorders. So how does that help us today? And thinking about, you know, some of the advancements in offering CBT for youth. This is a great summary by Kelly Banier and Eric Storch and their group, and really thinking about advances with respect to inhibitory learning principles, which we know, based a lot on the work of Michelle Krask and her team, that really are helping us to sort of supercharge our exposures, and how we think about our exposures, you know, in terms of focusing on tolerating discomfort rather than perhaps habituation, focusing on expectancy violation and things like that. So really enhancing and optimizing our exposure design. Use of technology, stay tuned for that. You will get a ton of that after me. And then increasing parental involvement, and really starting to think about, you know, these are 3 examples. We have the Kendall group from early on, who looked at individual CBT, family-based CBT, Coping Cat. I grew up with Coping Cat, so Coping Cat, shout out. And, you know, finding that, you know, for example, family-based CBT outperformed the individual version when both parents had an anxiety disorder, for example. And of course, the work of Dr. Golda Ginsberg and her team, and looking at the prevention of onset of disorders by directly, targeting parents, and through the Coping and Promoting Strengths program, teaching parents how to cope and really sort of preventing onset of anxiety in the youth up to a year later, and finding positive effects, very positive effects for that. And of course, Eli Leibowitz, who I know is on here, hello. So you can ask him later about the SPACE program, which is, supportive parenting for anxious childhood emotions, and really honing in on parent level intervention for anxiety, and really targeting parents as the sort of the point of intervention for addressing child anxiety in youth. And I'm hopeful that you'll get to ask Dr. Leibowitz some questions about that. And so really focusing on parents as sort of an entry point, and thinking about how do we work with parents, knowing what we just said about the effects of these times and the challenges of these times. We can't not talk about resilience, right? And so there's decades of resilience research, whether early trauma and extreme poverty and stress, led by the work of Ann Maston is extraordinary in terms of her book is called Ordinary Magic. And we know that resilience is a process of positively adapting to adversity, and we have adversity in spades. And again, if you look at the resilience literature, looking at capable and caregiving parenting, and then this other list that goes with it that are part of our intervention packages, really how do we target and help parents who we know are struggling. So how many ways to say this is that, when we look at youth, really looking at youth and caregivers, especially if we are considering the many, many, many challenges of our time. So strategy one, we should be caregiver focused. And I would love for us to lead with teaching parents how to have self-compassion and self-kindness in particular, because parents are out there beating themselves up. At least from what I am seeing, what I'm hearing, we see the amount of worry that they have, and understanding that we can help them by teaching them, and for all you parents out there, this is for you too, increasing the amount of compassion. This is a pandemic, nothing is normal. So how do we teach parents to sort of, remove some of the self-criticism and self-judgment that may be impairing and affecting them? And one is then also thinking about the system and the system focus, and what are the needs of a particular family, of a particular child, in terms of food or some of the basics, again, things that we may not always immediately think of with respect to our interventions. And then parents managing their own anxiety, like we talked about, having parent-focused interventions. And out of the gate, Jill Ehrenreich down at University of Miami, she has a study, and she's looking at 4 modules of, I believe it's called Co-Parent, has 4 modules of interventions that are parent level. I think it's 90 minutes each, and she's looking at giving parents skills to model their feelings. I think a healthy emotion modeling, and having parents observe their own emotions. Now, why do I have Lizzo come up? Because I love Lizzo, for the record. You should too. Why? Because Lizzo talks about self-care and self-kindness as self-preservation, and she really champions how we need to take care of ourselves. So I'm going to talk about social support and finding your team, and helping parents find their team, and helping kids find their team. And let me tell you, Lizzo is on my team because she's a reminder of taking care of ourselves always, but certainly now when the challenges are greater. Speaking of parents, we know that anxiety can be associated with perfectionism in parents, and over-parenting, which is sort of a misapplication of parenting and developmental level, not giving kids enough autonomy. We know that this has downstream effects in terms of youth having long-term impacts, perhaps from autonomy and not meeting developmental challenges, even substance use and other things. And there's an association between over-parenting and perfectionism. And what we want to get away from, and we know, again, if we're thinking about anxiety in youth, we know that there may be perfectionism for some in that system, either in the child, parents, or both. And really moving away from teaching, from parents or trying to get them to catch some of their perfectionism, and really focusing on effective parenting. And effective parenting is not perfect parenting. We know this, and it's especially true in a pandemic. So if we look at the trauma literature, we can get some answers to our questions about, there as well. John Comer and his team looked at, household discussions following the Boston Marathon bombing and the manhunt that ensued. And he looked at downstream post-traumatic stress in kids. And what they found, I thought, was so compelling, that when parents and caregivers had discussions about the marathon bombing and the manhunt and the ensuing, when they had direct discussions about that with their child, when parents talked about safety and encouraged and told kids why they were safe and whatnot, and when parents talked about their own feelings and expressed their own anxieties about it in an appropriate way, those kids showed fewer post-traumatic stress symptoms down the road, as opposed to when caregivers did not discuss what was happening with everything going on, when when they asked others to not discuss it in front of their kids, or when they were expressing significant anxieties about safety, those kids then were found to have higher rates of post-traumatic stress. So it's very important about how we communicate with all of this going on and trauma-related events happening around us. How do we get parents to have these discussions, talk more openly, because the data certainly support it. So, parents will say, how do I talk to my kids? It often starts with listening, right? So encouraging clinicians to assess family behaviors around communication. How are these talks happening? Are they happening? Are they not happening? And helping parents and families create a regular time and space to discuss feeling, and helping parents to show healthy emotion modeling of their own emotions. That's something that Jill's group also incorporates, whether it's a dinner time conversation or taking the walks or reflective listening. And of course, being mindful of age and development of the child. Another strategy that we focus on is validating and normalizing feelings that kids are experiencing. So very specific in terms of thinking about how do we validate. Often we want to jump to problem solving, and really helping parents validate there's so many feelings going around. I spoke to a friend's daughter who's 8 who went to school for an hour and a half yesterday, and she was so excited and so nervous. And it was both of those things, and how to encourage and validate. And yeah, that makes sense that you're both super nervous to see people and what's it going to be like, and excited to see friends and teachers, and then super nervous about what it's so unknown. And so helping parents to validate, and catching urges to fix or rescue or dismiss or problem solve. Oh, it's fine, it's going to be fine, right? So we want to catch and really on this very specific level help parents do that. And we have scripts. And this is a practice that I did with a family that I work with. Online school is stupid. I don't want to go. Yeah, I get it. Online work is stupid too sometimes, and so and validating that without saying, oh, but you have to, and this is, we'll get to that later. I just want to validate, like in that moment, yeah, online stuff is frustrating and annoying. My eyeballs are tired. Absolutely. What if I never get to see my friends again? Imagine being a child having that thought and validating, like it's really hard to think that we're never going to see folks again, and having that worry. And it makes sense because you haven't maybe seen friends or grandparents or whatever. So just validation practice, and maybe infusing that even more, and certainly infusing it based on some of the challenges we're experiencing. The other sort of broader topic related to what some of the research tells us from the trauma literature, whether it's the Boston bombing and manhunt or some of the post 9/11 stuff, and certainly some of the work, natural disasters. We want to limit news exposures, turn the television off, social media, it's everywhere, and really teaching parents and teaching kids how to be good consumers of information. Where are they getting information? In terms of the social media and how they're getting it. One of the girls in that video that I mentioned from the Atlantic said, oh yeah, I didn't even know about it. My friend told me about the coronavirus. And, so encouraging parents, like we said, to have these discussions and consider how is information getting in the house, and how might you want to consider that, and of course relying on science. See my earlier t-shirt, and helping families. And there are so many opportunities to teach kids about the science behind why wearing a mask. This is one visual example of this, Dr. Richard Davis. I just saw yesterday something recommended by Dr. Fauci. It's the slow-mo guys on YouTube, and they just put out a slow-mo video of sneezing, with a mask and whatnot. And so there are lots of ways to teach kids about the science behind wearing a mask or not, and how we're getting information, and where it's good to get information with masks, and some of the things that we are dealing with. And it's not just about the pandemic, right? I had a patient talk to me and start a conversation with her parents with respect to racial injustices and murders of Black people at the hands of police. And what started the conversation was the women's MBA. And that was the entry point, and encouraging her parents who felt like they, quote, didn't know what to say. how to say it, it was a source of great anxiety for this kid, and it was so important for them to have it. And the death of Chadwick Boseman was a great loss for a lot of young kids of color, and so encouraging parents to have these types of discussions and opening sort of the proverbial table, as it were, to have these discussions. If, by the way, you haven't seen this video, the Ron Clark Academy, that was when they won an opportunity to go to the movies to see Black Panther, and it's these kids dancing with excitement. It will lift your mood, and it's like a mood induction. It's amazing. So it will lift your spirits every time. So check it out if you can't. And then we know that with practice we get better at things, and parents want to skip ahead and be good at having these conversations, and it just takes practice, and it's fumbling and practicing and practicing. And so whether we're talking about practicing wearing masks, for some kids the reality, especially with anxiety disorders, there might be a lot of self-focus, which might make it difficult to wear masks legitimately. We want to validate that, and then we practice, right? And we help kids understand the importance of the mask, plus how to practice wearing the mask a little bit at a time, gradually, and increasing. Family we worked with, the young boy was having a hard time. He didn't want to wear masks. No. And he said he couldn't do it, and one of the things they did was they paired mask wear, which is brilliant, and I've used since with others, is practicing wearing a mask while playing video games. So if you want to play your video games, you have to play a video game with the mask on. And that was sort of and lo and behold, mask wearing improved and increased. And so, thinking about how we can change behaviors in the way that we know what to do. Modeling is another example. I am a Yankee fan, so I will gratuitously use Yankee examples. There are 3 throughout this talk. This is the first. Thinking about models. Who can we point out to model social learning theory, right? Who can we point out to model? By the way, Yogi Berra was also an amazing philosopher and great thinker, and he reframed lots of things. Clint Frazier, a Yankee who wore a mask throughout much of the season and out of respect for others, and he wound up just a couple days ago getting awarded the Golden Glove in addition to hitting a ton of home runs, and so thinking about how we are modeling and who the models are with some of these behaviors. And of course, we know that those who were in treatment, for example, for some of the anxiety and anxiety disorders, disrupted active and ongoing treatment. I think this tweet really made me laugh, and it's a great understanding of sort of how some of what is going on brought great relief for interesting reasons, which we'll talk about. So thinking about wearing a mask, and these are 2 quotes from patients of mine: between my hoodie and my mask, I'm good. I can walk around more. So there's the social invisibility, which we know that is associated with adults and youth with social anxiety, for that matter. Another kid asked me, would it be weird to wear a mask on Google Classroom? And yes, it would be weird to wear a mask on Google Classroom. And understanding the reasons and the functional reasons of why he would want to do that and why they would want to do that, and thinking about, okay, well, being careful to think about how there may be impacts, again, on specific social development. Masks may also result, for all we know, in greater attunement into social cues and being able to pay attention with more limited information or things like that for some, and being able to pay attention to how some of these things might actually be safety behaviors in the making, as we know, and how then we can incorporate. So same kid, as you can imagine, we were working on, yes, of course you have to wear the mask because that's the safe thing to do, but then not wearing the hoodie when he went out, not wearing, and then we talked about I have a collection of silly hats. I talked about, putting a silly hat in the mail to him that he would have to walk around with his mask and a silly hat as an exposure, and thinking about how we need to, account for some of these with, attending to social cues and role playing, not hearing someone and asking a follow-up question, and practicing doing that, setting up exposures, some of the assertiveness skills. Some kids are going back to school and getting teased for wearing masks, and how to account for some of these things. And a note on politics, right, that somehow mask use has been politicized, and with kids, and always going back to the science and public health and altruistic choice for wearing masks. And I would say very directly pointing out how masks have been politicized, and so that some of the information that goes to the information thing, again, we can account for. I'm also from New Jersey, so not gratuitous, Bruce Springsteen, the staying away, physical distancing. Technically, Bruce Springsteen apparently is 5'11". You can also do this with Queen Latifah, who's from my hometown. She's 5'10". So accounting more or less for, social distancing, and again, helping kids and encouraging kids to understand, perhaps in a fun way, the reasons for why we are doing things. And as I mentioned before, being mindful of this new world online. I think I mentioned that we had a social anxiety group that went now virtual, and we resumed now again. This is my family, by the way. It's not pictures of kids in team. Imagine having to show up to, Zoom celebrations, lots of people, don't know where to look, pairings and whatnot. And can you guess, and I got permission from her to show this slide, which family member is a little bit more socially anxious? Yeah, the one in the lower right-hand corner who's not showing her screen, and thinking about how we need to account for, the daily stuff that is happening with kids. And, related to that, the self-focused attention that comes with, for example, social anxiety. Susan Bogles and her group looked at this about 3 years ago and noted self-focused attention based on eye tracking gaze and how much we reference our own picture during a talk. I'm actually grateful that my face is not up here. I can't see, all I can see is the slides. It's a little weird that I can't see you guys, but probably less, it's better that I can't see myself. And what Susan and her team found, they found that not surprisingly, there was much more self-focused attention for people with social anxiety disorders rather than people who didn't, sort of across interactions, whether it was a warm conversation, critical conversation, sort of a warm-up conversation. Those with subclinical social anxiety only self-focused more when it was more critical. So again, not too surprising. And knowing, and we're hearing this in our sessions, is that they are focused on how they look. You're seeing much more self-referencing. And so again, thinking about that self-view in Zoom or Google or what have you, and how we design exposures around some of those challenges, and really paying attention to social skills deficits and some of the ways that we might need to help kids practice some of those deficits. And the struggle is real, man. This may be you guys right now, for all I know. And please feel free. I encourage you to just, and to presume that stance, and thinking about how do we prepare kids for this combination or this hybrid model, or going back to school, priming them and knowing that some of this stuff is harder, and what to do and how to practice, again, as part of maybe social challenges and exposures, and how do we use inhibitory learning principles, for example, to sort of supercharge some of those exposures with physiologic arousal, or with, with the boy that I mentioned earlier with the hoodie and the mask. One of the challenges he had to do is he had to sort of run in place to get his heart rate up before sitting down for one of his classes. And again, just to get some of this physiologic symptoms happening for him, just to sort of pair that with what was happening physically, and that he could tolerate and sort of ride it out and do the things that we know are effective. And really sort of acknowledging that there have been this social isolation. It is about, one of the most sort of foundational aspects of mental health we know is building social support, and having a social support. It doesn't need to be a huge team, but it could be a team. And how do we do that? If you're a child person, about gamifying. I can speak Fortnite now. I need to get a little better at Roblox. I don't know Roblox as well. I'm working on it. My native language is Pac-Man, for the record. So, I'm working on it, and helping kids sort of build, just like in a game or just like in a video game, build your sort of resources and build your coping tools and build your reserves. And, helping kids, and parents will say, look, you're calling your sister right now. One thing you can do is model and say, I'm calling Auntie so-and-so. She always makes me laugh. I need a good laugh. So modeling, sort of reaching out for help, modeling, hey, this person is on my team. And how do we build that social support? And who do you not want on your team, by the way? You get to pick who is on your team, and you get to pick who is not on your team. And, we don't want someone who's a critic, and we certainly don't want to be our own critic. So we don't want an internal critic or an external critic. And we can get rid of those. And we can get rid of lots of things, and so thinking about, how do we help kids build, social support, making friends, reaching out, joining. There are some, bonuses with having, online. We helped one kid join a book club that was being run through the library. It's virtual, and it's not ideal, and it's better than nothing in terms of being able to do some of these things. Being mindful of the time. I'll go for a couple more minutes. And helping kids sort of and parents focus on some of these things. So these are quotes from, how the heck do I do separation anxiety exposures when we're all in the same apartment? It's a great question. So thinking functionally about what some of the impairments are, and how do we create independence tasks or challenge tasks or separation tasks, being in one room versus the other. We have one family doing in the dark exposures, but in the bathroom. And so, doing the best we can. And, this one from another parent, I totally blew it and let her sleep in my bed since March. Well, March was kind of crazy. So let's forget and forgive March. And how do we get back? Development, remember, it's a path. We have a lot of time to sort of work on this stuff. And the totally blew it's like, look, we didn't know what the heck to do in March and April, and we still don't know largely what to do. But what we do know is that we need to teach her how to be able to soothe herself a bit, fall asleep on her own, do the things that we know that she can do, and then let's get to that rather than. And we know that there's a ton of uncertainty, and one of the things we are getting better at is helping to tolerate uncertainty. And so how do we do that? We focus on the overlap in the things that matter and the things that we can control. I reference this all the time. I printed a version of this. It's in my office, and helping parents focus on, how to tolerate. There's so many things we cannot answer. So how do we focus on what's in our control? What matters? Health and safety, mental health, making it personal for kids, learning over grades, and making the altruistic choice for each other, for our family, for our community, for our neighbors. And then, finding ways to help and have fun. So what's in your control? So many things are in our control. So many things are not in our control. But, there's hand washing, wearing a mask, of course, physical distances, taking a deep breath, what time you go to bed, volunteering, and, making the altruistic choice works. This is an example of out of New Zealand and Jacinda Ardern's Be Kind campaign, which predated the pandemic and really sort of was this sort of rallying cry for their country while they were in lockdown, and it motivated folks. And there's evidence to show that if we can convince people of the altruistic choice, we can have better effects of for example, of things like quarantine. And how do we create? Sorry, this is from Cheryl McNeil, who's amazing, by the way. If you've never seen her speak, have her do one of these forums. She's outstanding. So how do we create structure for kids? And basically, we want to do so by creating rules, routines, and rituals. And I'm going to focus on routines because we know that sleep is such an issue in parents, in kids. We're seeing that out of the early data coming out of COVID, and we know that it's associated with, we're seeing probable anxieties and other things going on. And so how do we schedule and get better and help parents get better about the sleep hygiene stuff, reinforcing behavior plans, movement, and getting outside. Again, there's good evidence that daily emotional well-being coming out. Again, they did a study that looked at people and how they spent time in quarantine. Of course, a lot of it was spent indoors. And when they did get outside, folks that got outside more and spent more time in nature doing activities, not surprisingly reported more positive affect and also less negative affect. So both of those were true. And thinking about, teaching caregivers their most powerful tools, attention, right? Specific label, praise. We know the work of Kuliafiko, Comer, and Albano. They modified some of the PCIT work specifically for younger kids with anxiety. And the Calm Project really focused on, helping parents to coach approach behavior. So reinforcing and praising brave behaviors to help them, sort of increase the likelihood that those behaviors would happen, and increasing approach that would decrease, anxiety disorders and the avoidance behaviors that are associated with them. So teaching parents to pay attention and do specific label praise for, I'm so proud of you for, I'm so happy that it helps me when and inserting specific label praise. As much as we like saying, wow, awesome, good job, unlabeled praise is just not as effective. So teaching parents what we already know, and just, I know, school is hard, I know things are complicated, I'm really proud of you for, getting on Zoom this morning on time, or getting on your classroom, or I'm so proud of you for sending that card to grandma, or, things that we want to attach with. We know that kids are worrying about the pandemic. We know that, we had a town hall with teens and young adults. They're worrying about, the effects of the pandemic, economic impacts. This is from a young adult and teen panel that we had. And we want to pay attention to, and then I'll end it here in the interest of time and take questions. This is the Launching Emerging Adult Forum. Anne-Marie Albano and her colleagues really taking a developmental functional assessment of targets for development. So a youth's ability in their transition from teen to emerging adult to manage their own finances, or pick out their own clothes, or make their own appointments, or have religious and political views and things like that that we know happen in transition into adulthood. And so really taking a developmental approach in terms of functionally what are kids doing, and there's good information. This is early data coming out of Anne-Marie's group, with kids with depression are more likely to have impairments in self-care and other things. Kids with social anxiety disorder are more likely to have functional impairments in social emotional activities in terms of making their own friends and following up and doing things with friends, etc. So really paying attention to sort of that in the context of these challenging times, and really targeting our approaches for these developmental milestones and tasks. And just as a reminder of how old I am, I make a Columbo reference and a shout out to Jill again, in terms of understanding what people worry about and open science, right? So Jill created this evaluation scale specifically for fear of illness and virus evaluation, and if you email her or tweet at her or something, she sends it to you. And if we want to assess COVID-related fears in specific, doing what we do best is, right, assessment as part of our treatments in terms of the symptomatology, as well as in terms of the functional impairments and whatnot. I said, this is the third one, Derek Jeter, now I can end it. So again, doing some of the cognitive work and picking out the models, and I'll leave it on hope. That's a good place to leave it. This is from our garden. Hope is a discipline, right? And so we know that youth anxiety have impairments in self-efficacy and self-agency. That's one of the functional impairments that we've found in other research. So part of the cognitive work, in addition to doing the exposures, doing a lot of the things that we have done, recognizing that we can teach kids to sort of practice hopeful behaviors too, as a form of self-efficacy and being a part of it. So hoping things get better, certainly, but how do I help? How do I help sort of the roll up your sleeves kind of hope, and giving them, and parents as well, to be, to give direction to some of their anxieties, for example, or some of the aspects for which they can deal with and cope with these challenging times. I have more slides, but I'll stop there. I'll end on where I was meaning to end. You can't go wrong if you have a Mr. Rogers in your talk. So I will end with Mr. Rogers with gratitude. I rambled on a bit. Let's see, let me get out of here. Okay. Oh, I'm back. There you are.
I just want to make sure that folks can hear me. Sandy, thank you so much. Mostly, I want to invite you to come live with me and raise my school-age daughter. But about that privately. I do see a couple of questions. I also wanted to ask some questions. We are a little tight on time.
Right.
So I'm gonna start with, sorry?
I just said sorry. And if anybody has questions, they can email via the webinar email, and I'm happy to answer them that way too, if that's easier or better.
No, never. Please don't apologize for having so much to share. I have to say, before I get to Diane Rosenbaum's question, Diane, I'm going to ask our tech folks, I think that's Vicky or Sasha, to unmute you in a moment to ask your question. But I will say that as my comment on self-focused attention and the data that you referenced, Sandy, is that there is actually a documented spike in plastic surgery among American women right now.
I just saw that,
which I find to be sort of tragic and telling, and no doubt related to what you're talking about. So there, I'm sorry? So I did want to invite Diane Rosenbaum to ask her question. Sasha, are you able to unmute Diane? I'm going to give it a moment. If not, then I'm going to ask.
I don't know if there's a choppy connection.
Diane, you are. Yeah, I'm unmuted. Can you hear me?
Yes, we can. Diane, go ahead.
Okay. How do you treat contamination OCD when the fear is COVID? I have a few kids in my practice who have OCD, and they're worried about getting it and also hurting other people in their family, and they're doing all the reassurance seeking and constantly evaluating, having wanting to take their temperature, and there is some reality to this, and I'm just wondering if you have any ideas.
Yeah, it's a great question, and certainly one that a lot of us are pondering. I just saw, I believe it was a case report, Eric Storch and his group just put something out with respect to this exact question. So I encourage you to I have it bookmarked somewhere on my 19 bookmarks that I need to catch up on, but I'm happy to email it to you. And in terms of the way that I would think about it is probably what we know. There's real danger, and we know that we cannot guarantee 100% certainty or absence of risk. And exposures need to be uncomfortable, but not unsafe, right? So finding that balance between what is excessive reassurance seeking or what is excessive washing and sanitizing or temperature taking, what are the recommendations as best we have them and know them, and trying to use those as sort of guideposts for sort of what the target behaviors be and then what should be, and then thinking about exposure and response prevention in terms of what do we need to do in terms of youth worrying about COVID or harming. We know that that's one of the largest sources of stress, and is associated is this worry about impacting others. And imagine that in a kid with OCD. So I don't know that we have great answers, but we know that there's real danger in many things, and we know that there's real danger with COVID. We want to talk about what are the direct and practical public health behaviors. Hand washing, distancing, hand washing for the 20 seconds, not a minute, hand washing once, not 10 times, right? So, and then trying to get kids based on what they're doing to sort of go back and say, okay, hand washing, what we typically do in an exposure and response prevention paradigm, and trying to target it more adaptively.
Thank you.
Yeah, good question.
Thank you. So there's a really fantastic question from Deborah Ledley. I'm going to invite her to, or actually rather ask Sasha or Vicky to unmute her. This will be our last question just in the interest of time, but please do go ahead and continue to put your questions in the chat box. I'm sure Sandy would be able to get back to you privately. Or feel free to email us at the ADAA at the webinar's email address that has been shared already. Deborah, do you want to, are you unmuted? Can you ask your question?
Deborah should be.
If not, I'll go ahead and read it.
Barbara, I'd go ahead and read it.
Okay, I'm going to go ahead and read it on her behalf. Deborah Ledley says, in the past few weeks, so many parents have been asking me how to explain to their kids if the election doesn't turn out as they hope next week. As we all know, politics have entered the therapy room these past few years. I don't know what I would say to my own kids, so this one leaves me speechless.
Oh, Deb. Oh. Yeah, I mean, I think we, at least today, right? I don't know what's going to happen on November 3rd. We don't know what's going to happen on November 4th or 5th, probably. And so I would I would have the conversation. I wouldn't avoid it, right? We know that that's one of the more important things. I would talk about my feelings within what's appropriate for however old your kids are. By the way, Deb, in my mind, your kids are still little and baby. And I know that's not true, but I don't want to know how old they are, actually. And I would have the conversation. I wouldn't avoid it, and I would ask questions and be curious with kids and listen to what they are worried about. So what would they be worried about if it goes one way versus another? What would they do? What are the specific worries and concerns? We may be able to provide reassurances, we may not, and being able to tolerate some of that. There's nothing we can do about that today with respect to knowing the outcome. What can we do today with respect to what's in our control? In terms of voting, in terms of supporting folks who are voting, in terms of, I went to early vote in New York, and I waited in line for 4 years. I waited in line for 4 years. That's actually true. For four hours. And there was a woman and her daughter giving out little hand packages of Oreo cookies in this distance way, these little water bottles. I'm like, that's amazing. And so I would focus on what's in our control today. Today is Thursday. We'll see what happens Friday, Saturday, Sunday, Monday, Tuesday. We know that there's going to be a good amount of stress, I think probably specifically on Tuesday. So creating time for outdoor activities or exercise or self-care, you know, Lizzo, you know, something that I know Deb, you love classical music, and I would find time to do family stuff to the extent possible. I would limit the news. I would not have CNN on with the Carnegie big board I just wouldn't, because it's going to be stressful. So I would be the funnel and the manager of information. Again, it depends on how old your kids are. If they're teenagers, they may have their own direct access, and I would try to teach them, saying, look, if we constantly, you know, doom scroll or you know, get stuck, let's pick the times when we're going to check, or let's pick the resource that we're going to check in advance. And that's how I might handle at least these days leading up to it and the actual day. And, you know, sort of reinforcing that I don't know what's going to happen, and I have some good faith that we will be able to handle whatever happens, and we will figure it out. So it's sort of this hope for the figuring out part of it. I don't know if that answers your question. That's what I'm doing. So.
All right. Well, thank you. I think along with, there have been a lot of requests in the chat for slides, and also for some of just the names that you rattled off so expertly, Sandy. I think it might also be very important to include, I think it was eBay or Etsy where you got that T-shirt. We might need that link for folks as well.
Yes, gladly, on all fronts, and please feel free to, you know, reach out as needed. I'll share the slides and whatever you guys need. Thank you.
Sandy has a great political T-shirt collection. It's the envy of many of us. So thank you for that. So I do want to go ahead and transition. By Sandy. I do want to go ahead and transition us. We have another wonderful speaker. We're really sort of have an embarrassment of riches today. Dr. Mona Patel is a child and adolescent psychiatrist. Excuse me. She is medical director at McLean Child Outpatient Services, including McLean Anxiety Mastery Program, McLean School Consultation Service, and the DBT Outpatient Program. She serves on the executive committee for the McLean Institute of Technology and Psychiatry. She's an instructor in psychiatry at Harvard Medical School and associate training director for MGH McLean Child Psychiatry Fellowship. So thank you so much, Mona, for being with us, and I will turn it over to you. Just a reminder, actually, before I do, please feel free, anybody, to put a question in the chat at any point. I'll be keeping my eye on that, and on to you, Mona. Thanks.
Thank you, Barbara. And Sandy, that was an awesome presentation. I, not only as a clinician, but as a parent, I just feel so much more well-equipped. So really awesome, appreciated that. And thank you, ADAA, for having me, and for everyone for joining. I have to say that this definitely feels awkward. I really miss getting to actually see you in person, and it's going to feel even stranger to just be looking at my slides, but we will do what we can. We are talking about anxiety after all. So let's see. I'm going to figure it out. Okay, can people see my screen? Hopefully, yes.
Screen is being shared.
Awesome. Okay. Barrier 1 complete. Okay, now let's see if I can get it on slideshow, and then here we go. Okay. Awesome. So we are going to talk a little bit about innovations in child and adolescent psychiatry treatment. And let's see, how do I advance my slides? Okay, glitch number 1. Okay, here we go. Oh, there we go, figured it out. Sorry about that. So Sandy said, got to have some objectives, so we'll lay them out here. So I'll first talk through some of the current standards of care for pediatric anxiety disorder, specifically in meds and therapy. Then I'll highlight some complementary and integrative medicine options. And then we'll also think through some innovation options through technology. And a little spoiler alert, I'm really excited to talk about some of the virtual reality work that we have just started to do in our clinic. So I'm looking forward to talking through some of that. While this is not relevant to my talk today, I did want to make sure that I mentioned that my husband is actually leading a measurement-based care behavioral health company, and I'm a clinical advisor to that. And I will also be talking through medications in this talk, and so wanted to just say that most of these medications are actually used off-label in children and adolescents, and so I just listed out some of the FDA indications for them here, just so that you can take a look. And so Sandy gave a great overview of development, and you can see how the different anxiety disorders map onto development over time. And as Sandy mentioned, it can be really disruptive if anxiety interferes with learning at these different stages. And so, and then that disruption can lead to secondary, tertiary problems, which then worsen the anxiety and becomes this terrible cycle. And so this is just my plug to say, hey, you know what, let's intervene as early as possible. Interventions don't have to be huge, but even doing kind of small things like modeling behaviors and really thinking about how we're approaching anxiety can make a huge difference in the long term. I'm sure I'm preaching to the choir, but just felt like I really needed to say that. And we know so much more about anxiety than we did even a decade ago, including the impact of biology, of psychology, and environmental factors in how anxiety is expressed and how it kind of falls in its course. And so really want to make sure that we're taking into account all of these different factors as we think about treatment. And I know Sandy briefly talked through CAMS and CAMELS, but they have been such a huge, they've had such a huge impact in how I talk about anxiety treatment with my families and patients who come to us. And so I just wanted to give a shout out to Dr. Walkup and team for the work they've done for this, because it's been such a huge contribution, and wanted to talk through just a couple of highlights, just to, again, so I'll keep referencing it throughout my talk. And so again, really quickly, so 4 intervention or 4 groups: placebo, sertraline alone, CBT alone, and CBT plus sertraline. Kids with anxiety, 488 of them. And at the end of 12 weeks, what they found was that response rates in blue were really good. So yay, we have some good treatment that actually works. And then they looked at remission rates, and those were much lower. Still significant for the combination group, but unfortunately not so yay, because we need to do better there. And then they looked at an extended version of this. And so they followed 319 of the CAMS kids for 4 years in a row, an average of 6.5 years after that initial randomization. Super cool to get such a longitudinal view of these kids. And the good news is that of the kids that responded at 12 weeks, many of them actually went on to have remission at some point during that 4-year follow-up. So that was great. So again, yay, when treatment works, it sustains over time for many kids. So that was great. But when they looked at the kind of the groups over the course of those 4 years, what they found was that the majority of the kids, as Sandy mentioned, were going in and out of symptomatic diagnosis. And then many of them were chronically ill. And only about 21% of them were actually constant remitters. So only 20% actually stayed well in the long run. And so that's the not so yay part, where we really, as Sandy mentioned, need to think about anxiety in kids as potentially more of a chronic disorder. And we really need to think about how we're delivering treatment and what treatments we're delivering. On a slightly brighter note, the functional outcomes did look better in several domains. And one thing that was notable was that the CBT group actually separated out from placebo in several of the functional domains, which also makes you wonder when you're thinking about CBT versus meds, if CBT kind of helps, like, again, train that brain in a different way. And so it'd be really helpful to know which kids do better and which kids don't with the treatments with our standard treatments. And we're getting more and more information, again, thanks to our fabulous researchers out there. And so I've listed out some of the predictors of better outcomes in CAMS and CAMELS. I wanted to highlight a couple of them. Specifically, lower caregiver strain in CAMS and better family functioning in CAMELS made a difference. And Sandy gave a great argument for really addressing that family system and for what to do there. And another one that was really interesting was that no diagnosis of social phobia actually predicted better outcome. And they actually saw that the kids with social phobia did better when they were in a sertraline treatment group, so whether combination or in sertraline alone. And so, there are a couple of potential takeaways from this. Maybe you consider medication earlier in somebody who has social phobia, or maybe kids with social phobia need a different approach to the CBT that from what was delivered in CAMS or maybe some augmentation. But again, really helpful information as we think about the treatment. And so we know a lot about anxiety and treatment, and we have some really important questions that we need to answer. And so we know that many kids do well with the treatment that we have to offer in the short run, but how do we improve acute remission? And then how do we make it stick over time? So how do we optimize our treatment options? And what are the ways to keep kids and families engaged in continued emotional learning over time that are also acceptable and feasible, given that there are finite resources, right? I mean, we definitely have a supply and demand problem in our field. We know that. And then what do we do for the kids who do not respond to a CAM style treatment approach? There's not really a lot of great data looking at kind of the treatment resistant or non-responder kids. And so we really rely a lot on kind of clinical expertise right now to answer some of these questions. And there's not a lot of time to go through everything, all the possible answers, but as I mentioned earlier, I will talk through how we optimize medications, how we might optimize medications and therapy approaches, how we might consider some complementary medicine options, and again, how we might incorporate technology to innovate and explore beyond kind of what we have presently available. The longer I do this, the more I feel convinced that, again, we need to attack this problem from multiple angles and really think about that biology, psychology, and social piece. Okay, so first let's start by talking about medications. And so in our clinic, we see the whole range of kids, from kids and families who are just very reluctant to try medications, whether it's because they fear the side effects or the risks associated with medications, or some of our kids are really tied to their anxiety. They find it really protective and they want to tackle it on their terms, not on the terms of a medication that they worry might dull their ability to be vigilant and watch out for what they need to watch out for. And then we see on the other end of the spectrum, kids who come in and it feels like they're walking pharmacies, where we just really need to think about how we simplify their meds, because they're not even sure why they're on which med and what that medication is doing. And so when we talk through medications, we talk through the risks and benefits, but we talk through the pros and cons, not only of medicating, but also of not medicating. So again, if we think about anxiety on a developmental level and how much it can actually rob somebody of meeting the milestones that they're supposed to meet at each level, time matters. And so really we talk about, well, how much can you afford to have anxiety be this big at this, or do we need to try to get to a quicker response, or at least tackle it in a more robust way? Do we want to tackle that biology piece as we also tackle some of the other pieces, to maybe even take down the intensity of the symptoms so that the patient can then engage in the therapy and train their brain? And so the first step in optimizing, we want to think about how we optimize the medication treatment. And the first step is to think about how we ensure an adequate trial. So that includes making sure there's compliance with the right medication, the right therapeutic dose, and a sufficient duration of time. And so I know it sounds silly, but make sure they're taking their medications. I've actually started deliberately asking, because what I found is that a lot of kids, especially our anxious kids, are so somatic and so anxious that compliance is oftentimes a problem. In CAMS, they found actually that compliance with medication was higher in the CBT plus sertraline group than in the sertraline group. And you can hypothesize that this might be because in the CBT group, they're also working on some of those somatic complaints, and so they might have a better handle on some of those physical sensations. And then there was a recent meta-analysis that has given us some really good, helpful information as we think about the medications. So they showed that when put head-to-head, SSRIs have shown more rapid and greater improvements compared to SNRIs. So kind of solidified our, clinical thinking. SSRIs are our first line. With respect to dosing, they found that high dose might not necessarily be better, but we do need to remember that blood levels vary by the individual. And there's been some talk, about considering pharmacogenetic testing in specific situations. For example, when you've got somebody who's a non-responder or somebody who has a lot of high side effects, to get a sense of whether they might be a rapid or slow metabolizer and how that might impact dosing. So right now, still the thinking is to be very individualized about how we're thinking about it. But we do want to make sure that it's at least of a sufficient duration. So we'll usually see some benefit by 2 weeks, but a real trial lasts at least 8 weeks on the maximum therapeutic dose that's tolerated. And so what other options do we have for those kids who do not respond to this standard treatment? So we actually have a lot of options to target pediatric anxiety, but not a lot of evidence to back them up. And so we usually go off label and we ask each other, lots of expert opinion kind of helping us figure out what to do next. And I actually love talking about medications, and I also realize that we have a very broad audience here. And so I will resist the urge to go through all of these on this list, but I'll highlight a couple, and then I'm happy to revisit it in the question and answer if that is of interest to anyone. But when thinking about augmentation, one thing to note is that it doesn't have to be long-term. It can be a short-term bridge to help give the SSRI and therapy a chance to actually start working. So one of the big ways we use it in our clinic is through benzodiazepines. And so, for example, if a child just has a really hard time just even engaging, and so like when we were in person, it'd be if they had a hard time getting in clinic, now it's kind of like if we really can't get them to even show up on the screen, and parents have done everything, we've tried everything, we might try a low dose of benzo, and we'll very clearly say, look, this is a 2 to 4 week trial max. This is in service of really taking down the anxiety so that you can even come and talk to us and engage in the exposure work and engage in the cognitive work, and really use it as that kind of initial gate. And while we do have meds that are helpful, as a child psychiatrist, I'm constantly looking to see what else is out there. And so there has been some recent interest on the glutamate system through the NMDA receptor system. That system kind of potentially helps with emotional learning and fear extinction. So in theory, yeah, sounds great. In practice, most of these meds are most of these meds are being used. Although, I mean, talking with my colleagues, I don't know that any of us have found this earth-shattering change. So oftentimes we just use them in augmentation. The one that I'm really excited about is D-cycloserine, though it's not available yet, but it has a different mechanism of action. So it is not one that you have to take on a daily basis, and its function is to actually enhance exposure. And so you take it around an exposure. And so, again, really cool concept, and from a neurobiological perspective, makes a whole lot of sense. Unfortunately, the data are actually quite mixed, and so we still haven't quite figured out how to use it in a way that translates to clinical practice, but it's one to definitely keep an eye out on. Okay, so I talked about optimizing and augmenting medications. Now let's think about some ways to optimize therapy as we aim for, again, that short-term remission, and then figure out how to help it stick, and then also thinking about how we augment the therapy to help those people who don't respond to CBT alone. So with CBT, what helps outcomes? Well, so just like medications, let's first make sure they actually got CBT. I know this sounds really silly, but we see this in our clinic all the time. A patient comes to us and says, yes, I've tried CBT, it didn't work for me, and they feel hopeless that this, tried and true standard of care doesn't work. And when we dig a little deeper, they didn't actually get CBT. So we really highlight that point. And this is where technology can potentially be helpful. I'll mention that in a bit. And then another piece is don't forget the B. So many of us feel really comfortable doing the C, the cognitive piece of things, but I cannot say enough that that behavioral piece, that exposure, is really key. So we really think about kind of making exposure like kind of a way of life. So approach over avoidance, whether it's in therapy, at home, at school, in the community, we surround sound it. And really, the more experience these kids have facing their fears and discomfort, whether it's in places, things, feelings, the more they're really retraining their brain. And we really talk a lot about just retraining that brain. And so we want to really optimize the therapy to help build those new memories and then help them stick over time. So Sandy went through inhibitory learning, could not agree more that it's something that can really help that exposure just have kind of set in that new learning and then stick over time. She also mentioned the caregiver involvement, and this one in particular, I'd say in our clinic is the one intervention piece that we have just ramped up more and more over time. It's just seeing how much of a high impact that can have. Wanted to give a little story as an aside. It was really interesting for me where one of my friends came to me and to kind of ask some advice about their 10-year-old son, who'd been struggling with anxiety, and he had gone through. He just recently finished a short course of CBT, and actually responded well to the CBT. Didn't hit remission, but did respond. And the parents said, okay, so he did well, and the therapist is now saying he's ready to finish CBT, like he's all done with treatment and he's good to go. And they were feeling nervous about it. And so what I did was I talked them through the CAMELS data and said, yeah, this is awesome. Like, glad he had a good response. And let's think together about how we might help with maintenance to make sure that he's keeping this new learning up. And so we talked a lot about those parent strategies that Sandy mentioned in her talk, right? How do you as parents continue to model this new behavior? How do you reinforce the learning? How do you give him opportunities for exposure to keep trying this, so that this new way of thinking, this new way of approaching that anxiety becomes the new norm and it sticks, and instead of it kind of slowly reverting back to what he was doing before, because it was kind of an acute learning event. And so again, this argument for how do we keep it going? And the data are showing more and more, again, that positive expectations matter. Sandy mentioned hope. That when caregivers and the children and the patients actually feel like this is going to be helpful, they're more likely to engage in the therapy. They're more likely to be willing to do harder sessions, and this directly impacts the outcome. So that psychoeducation is really key. Make sure you're explaining what they're going to do, why they're doing it, and that it can really work if they stick to it. Okay, but so we know, again, from CAMS that CBT doesn't work for everyone. And so similar to medications, if CBT isn't sufficient, then maybe we think about augmenting. And as a psychiatrist, this is particularly, I love this because I'll pull little pieces, right? The modular treatments are great because you can pull pieces and skills and concepts, and in a very quick way kind of help reinforce kind of learning for different pieces. In our clinic, we tend to use motivational interviewing a lot. So what happens is in child and adolescent psychiatry, a lot of times it's not the kid who's coming and saying, oh, I really need help. It's the parents bringing them in. And the kid is ambivalent at best about engaging in treatment. And so what we find is that if we try to dive right into treatment and they're not where we are, then it's like pushing a boulder up a mountain. It's painful for everyone. And so we really think about the stages of change and think about motivational interviewing to help enhance that interest, willingness, motivation to do this really hard work, because it is much easier to just avoid and not have to feel those uncomfortable feelings. We also tend to use, especially in our older kids, in our adolescents, we'll use some value-based work from ACT to really help with that motivation. In the kids, we tend to use more rewards. And then DBT, or dialectical behavior therapy, is one that I really like when it's helpful to dial down the intensity of the emotions and that kind of maladaptive coping that can come when somebody's feeling really intensely anxious. I love the states of mind, tend to refer to them quite a bit. So what state of mind are you in right now? What's driving your decision making? Is it the emotions? And if it is the emotions, then maybe what can you do to take down the emotions a little bit so that you can actually, so that you're the one who's making the decisions. And we'll talk through some skills in order to dial down those heavy emotions. Okay, so now let's switch gears and talk a little bit about complementary and integrative medicine. So a lot of parents who come to our clinic ask about this, and so I found it important to stay up to date with the literature, not only so I can engage in a conversation with them, but also to keep an open mind, again, as we think about how do we attack this from different angles and how do we get creative in what we're doing. The unfortunate part is that most of the complementary options just don't have enough evidence to support their use as monotherapy or on their own, but they can really be good adjuncts. So I'll go through a couple of quick highlights. So I know that people, my colleagues and friends in my clinic are kind of sick of hearing me talking about this, but I'm super fascinated by that gut-brain association. You know, there's trillions of microorganisms that live in your gut. They talked, and they, you know, kind of this cross influence with the brain and mental health, but also with other systems in your body, like your immune system and your endocrine system, and just really cool studies in mice, but still cool studies where they've shown how you can transfer an anxious phenotype from one mouse to another by transferring the gut microbiota, and then also how you can use by altering bacteria in the gut, you can help treat some disorders of stress. So interesting stuff. We still need some more studies and research in humans, but what's really helpful is that there's a potential for intervention in that our environment, specifically our diet, can really impact what is in our gut. So, those microbiota. And so a healthy diet with a variety of foods can be good. So I'll often refer my patients to the choosemyplate.gov website. It's got some helpful information there. And Sandy had mentioned food insecurity, and I do want to acknowledge that this is not always easy. And so some of us have more privilege than others to be able to really think about this. And that being said, it can still be valuable to help them try to think through how they're making decisions, because it could have a big impact. Probiotics have also gotten a lot of attention, and in the adult literature, there's been quite a bit of research looking at their efficacy for anxiety and depression. And it's interesting because the data are mixed. One meta-analysis recently found that there is some benefit in anxiety, another one found not so much. I think the hard part is that probiotics themselves are not regulated, so they can vary in even what's in them. So I think there is still information that we need to know in terms of like what kind of bacteria to include, how much of them, and in what way to use the probiotics. And so, so in my clinic, what I'll often do is just say, hey, you know what, probiotics potentially matter. And so if you can get this through your diet, like if you can increase like the yogurt or kefir or sauerkraut and pickles are a little bit harder with the kids, but it can make a difference potentially. Natural remedies have some, so many of them have been looked at to see how they might impact anxiety and stress, but there's really limited evidence. And so none has really reached the status of saying, yes, like this is something that can really be considered for treatment, especially in children and adolescents. Two of them have gotten extra attention, kava kava and lavender, but unfortunately, both of them are limited also by potential side effects. In kava kava, you've got to watch the liver function tests. And in lavender, they've found that that it can potentially mimic the actions of estrogen and inhibits the effects of androgens. And so it's a possible endocrine disruptor. So again, as kids are in that puberty stage, probably want to stay away from it. But again, still trying to understand what this means. Okay, so I wish I could see all of you, but I'd say right now that wherever you're sitting, whatever you're doing, let's practice what we preach. I'm going to talk a little about yoga, so maybe you can do a little stretch break, and I can't see myself, so I don't know how silly I look, so I think I'll refrain from doing a little yoga stretch break. But I am personally really excited about yoga just because it hits not only the psychological piece of anxiety, but also that physiology. So again, tackling it from multiple different angles. And there have been a lot of studies that have actually shown that yoga can be helpful for anxiety, but they've got kind of a big range of quality and methodology. So that might slow down kind of our ability to translate it, although we're seeing some more of it kind of go into school settings, for example. So wanted to talk through really quickly a cool study that one of my colleagues at McLean just completed. She's a neuroscientist, and it's a cool so it's an NIH-funded Ayana yoga study. And so it was originally planned to be a neuroimaging study, but COVID hit and plans changed. I'm sure no one knows what that feels like. But they shifted to delivering yoga via synchronous Zoom sessions twice a week, and then asynchronous Zoom sessions twice a week. So there are 4 sessions per week, and there were adolescents divided into 2 groups, one group with major depressive disorder, and the other group was a healthy control group. And what she found was really notable was that in both groups, their anxiety symptoms actually went down by 4 weeks. And what was particularly cool also was that this was all done virtually. And so it's kind of, again, as we're thinking about in COVID times, how do we adapt a potential additional tool that could be helpful. And so last but not least of the complementary strategies, I do want to mention exercise only because this is my go-to. I might have been listening to some Beyonce and having a little dance party before I logged in to this virtual live meeting. it's just something that I feel like hits so many different angles, so you get a really big bang for your buck. And so I know all of you know the benefits of exercise, so I'm not going to take a lot of time going through this one, but I will say that in our clinic we talk about that intense exercise being really helpful in those moments of high emotion when you just need to kind of shake yourself out of that stuck place. And, some people like that deep breathing and relaxation, but for some people, they just really need to just jolt themselves through some kind of intense math. And then we also talk about kind of having it as a regular practice over time. Okay, and now to our final category. I wanted to, so the thing that I really love about my job is that I get to practice evidence-based care while also having this hat on of innovation and change, and really thinking about how we improve effectiveness, engagement, and access for all of our patients. And so technology has the potential to help with short-term outcomes, with maintenance over time, how to get, it helps us to potentially get creative in capturing kids who don't respond to treatment. And it helps with an additional piece, and that's access, right? There are a lot of kids and adolescents out there and families who can't even access treatment. And so technology is one potential solution to that. Now, I do want to say that we've got a great expert panel who's going to be talking about the good and the bad of technology. And I want to acknowledge that while there's great opportunity here, it doesn't come without some risks and downsides that are also important to pay attention to. So I did want to highlight that piece, and our panel will totally take it from there. And so I plan to talk through some innovations that including telehealth. So let me see how we're doing with time. Okay, so in the interest of time, what I might do is try to really rush through, or not rush through, but relatively quickly go through telehealth, computer-based CBT apps, and cognitive bias modification, and try to leave a little extra time for the virtual reality work that we're doing in our program. So almost overnight, telepsychiatry went from being potentially innovative to being completely mainstream. So I'm not going to spend too much time on this one. I'm sure many of you can probably relate to this cartoon that was run by the New Yorker over the summer, though perhaps you might have chosen to put on some yoga pants or exercise pants in case you accidentally forgot you were on screen and stood up. Although that never happened. Okay. And I have to say that I'm just so impressed and blown away by our team at McLean and how creative they've gotten in providing virtual treatment, particularly exposures. And Sandy referenced this quite a bit as well, but in the 7 months that we've been providing treatment virtually, we've yet to find an exposure target that we've not been able to somehow figure out how to do virtually. And so that's been really cool and exciting. I mean, I think what's been, and we've actually found some situations where it's actually been almost helpful to be able to do it virtually. So for example, I mean, again, we have to in COVID times think about how to do it safely and thoughtfully, but we've had kids who with social phobia kind of like put in their earbuds, take their phone and take our therapist with them into the mall, and the therapist is coaching them along the way. And so it kind of expanded the ability of places that we could actually engage patients in for their exposures. Could also take it into the house, and parents could watch kids do their exposure and see how the therapist is coaching them and learn from that. And then we can also see how the parent and child are interaction and give some parent coaching as well. So again, expanded options. As Sandy mentioned, kids with social anxiety, in particular, we've had a lot of extra work to just get them on the screen. And so that's been one of our bigger challenges that we've taken on, but we're still working through. So computer-based CBT or ICBT is the tech intervention that has the most research support to back it. We're really excited about this one because it can make us more efficient. So it can really solve this problem of access. And I talked about how it can help with maintenance when I talked about my friend's son, right? Again, could he, after he's learned the CBT, kind of keep engaging in some kind of program or game like this that might help him remember what he's learned, and again, keep integrating it. We in our clinic often talk about, could we have something like this to give to the parents and kids who come in and are sitting on our wait list. It is so devastating to think about these families and to not be able to give the families the care exactly like when they come and ask for it. And so we're constantly trying to think, how do we help these families who can't get treatment right away. And so we've wondered if, if we could give them this kind of computerized CBT, they can learn the skills. And then when they get to us, they've already learned the basics, and then we can go deeper in with them. And so that also makes us more efficient potentially. So some area for potential really good growth and learning here. I wanted to highlight 2 specific ICBT programs that I find really interesting. The first one is Sparks. And so Sparks is a gamified, it's a fantasy game actually. And so they actually did they asked a lot of kids kind of what they wanted. And the kids were saying they want complicated game and they didn't want to have to read anything. And so they created this 7-module CBT based game. And actually the New Zealand Prime Minister launched it publicly in April of 2014. Now, the biggest problem here was that in research setting, they had about a 90% compliance, but then in public domain, they had about 3% compliance or engagement. And so with ICBT, the biggest limiting factor right now is actually that engagement. And so there's a lot of work now being done by the Sparks team to figure out how do we improve that engagement. And it's actually been converted to an app. And one of our colleagues, Helen Christensen in Australia, is actually launching it with a goal. I think they've had it used by about 2,000 students so far, and they're aiming for 20,000 students. And they incorporated some digital phenotyping to really see if they can kind of predict who might need more treatment. So again, some really cool stuff happening with the Sparks team. And if we move back to the US, the Kids Face Fear project is a really cool one too. So it's a hybrid implementation and effectiveness project. And so they're going to compare face-to-face CBT with online CBT for over 1,800 kids aged 13 to 18. And they're really working on that engagement piece too. How do we make sure that we are engaging kids so that they learn something from this? So their trial is going to run until 2025. So we might have to wait a bit until we get to hear what the results are, but still really promising. So a little bit about apps. And so apps, again, similar to ICBT, have a lot of opportunity to answer those questions that about access and remission and treatment and maintaining treatment games. And the primary ways that we have found apps helpful in our clinic are through reward charts, as well as through mindfulness and relaxation apps. We're still kind of hungry for more, and we're watching anxiously to see how some of our researchers come out with things like the Sparks games and Kids Face Fear to see if we can use them in more broad ways. But for now, there are some limitations with the apps. One, that there's limited evidence to support them, and a lot of the evidence that's out there is done by the app producers. And there's low engagement similar to ICBT. So people will engage in it, but there's not a great staying power. We've seen this both with patients and with clinicians. Although there has been question about what is kind of our standard of measurement for, or what is our goal for engagement. And so, there's some thought that perhaps apps are used differently from how we're used to using therapeutic tools. So for example, maybe a patient will go in, get something out of the app and leave it. And so even though they didn't stay engaged over time, there was still something that was beneficial about it. My son actually helped demonstrate this pretty well, right? He's 9, and I've been trying to teach him kind of breathing exercises, tried all of my kind of like different tactics and like blow out the candles, all of that. And he'd kind of look at me like, Mom, that is really silly, and stop treating me like a baby, and I don't want to do that. And then he found this silly kind of like blow a bubble breathing game on my husband's Apple Watch. And all of a sudden he thinks breathing is the coolest thing. He doesn't have to keep engaging with it over time, but it was that one piece of information. It was something that got him engaged. And now he's willing to try this thing that I had been trying to get him to do in a different way. So maybe apps can, provide some different way of engaging or learning some of the tools that we want to give. And then finally, privacy and security is a big deal with apps, especially the commercially available ones. Many of them will say that they're not medical devices, and so they're not subject to medical privacy regulations. And that means that they can capture all kinds of data from your cell phone and either use it for their own marketing or sell it. And so especially with kids and adolescents, we just really want to be careful about that. And so just wanted to give a couple of resources for evaluating apps for those of you who want to use apps, again, because they can be super helpful. The American Psychiatric Association has kind of divided measurement of apps into 5 categories: accessibility, privacy and security, clinical foundation, engagement style, and data sharing. And so, so that's one option. Cyber Guide is a really cool one where you can look at apps by their category, and then they will give you information about credibility, user experience, transparency, and then they'll go through any research that's available on it, as well as they've had professionals in our field actually evaluate them. And so it's kind of a nice, quick way to try to take a look at something. And then the last one is the BI Deaconess has also given kind of a similar, sorry, I'm looking at the chats too. This is a whole new like information overload. I'm looking at little chats popping up, so sorry about the little distraction. But you can see the different categories coming up as well. And I won't spend a lot of time on this in the interest of time, but I do want to mention, so I got to talk to Shekhar Saxena, who's at the WHO, and they're doing some really cool things through apps to increase global access to care. The one I'll highlight on this is the Schwatch at the bottom left. So it's been running it for about 2 months in India, so it's kind of hot off the press, but it's this kind of global gateway where they're kind of compiling a lot of different apps, and so a patient can go there and kind of figure out what they need and get what they need in a curated way. And it's this app is a partnership between public and private sector, so the government and private companies. And so a lot of what they're offering is for free, although some of this stuff is going to be also at a premium. So I thought that was really interesting. And then the World Economic Forum and Deloitte are working on a project for governance and ethics in digital technology that they're actually piloting in New Zealand. Because again, as we start thinking about how to integrate this really cool stuff, we do need to think about kind of how do we do it in a thoughtful way. And so on the one hand, like really taking into consideration all those those risks and the ethics piece of it. And on the other hand, also making sure that we're not being so bogged down by that we're missing out on opportunity to access care and to expand what we're doing to help patients. So cognitive bias modification is another one that it's kind of like DCS. I'm like really excited about it. It seems fantastic from a neurobiological perspective, but we're still trying to figure out how best to use it clinically. And so it's one that it's on my high list of like, come on, I really, really want to be able to use this in the clinical world. And so really quickly, for those of you who are less familiar with it, since I know we have a broad audience, cognitive bias is based on the findings that some anxious brains are neurobiologically vulnerable to automatic biases. So whether it might, and so for example, in a bias can be an attention bias to threat, or it can be a bias to interpret neutral cues as threatening. And so while CBT and mindfulness aim to kind of target these biases from top down brain processing, like so you're working on the cognitions and the conscious attention, cognitive bias modification aims to target these from the bottom up processing. And so that's why I think this is really exciting. Again, you can attack the problem from multiple different angles. So attention bias modification usually uses the dot probe task or the visual search task. If you look at apps, oftentimes that's what you'll find is the visual search, where you look for that happy face amongst all the not so happy faces. In our clinic, we did try the dot probe. You have to go through hundreds of repetitions. And what we found with our kids and adolescents is they did not have the patience to complete it without an adult right there over them. So that was a limitation. The interpretation bias will go through an ambiguous scenario, and then we'll end it with a positive resolution in order to, again, retrain that bias. So, you text a friend to hang out, you're waiting for a text back, your friend will think your text is, so oftentimes the interpretation bias is it's boring, they don't want to hang out with me. So it's kind of trying to retrain that automatic thinking that might be coming up. And so I was really excited to see in the Orange Journal, actually very recently, a randomized controlled trial. And this one was interesting for 2 reasons. One, as I mentioned earlier, there are not a lot of trials looking at what do we do next when kids are not responsive to to kind of that standard CBT kind of CAMS type treatment. And so they took kids who were treatment non-responders in their study to CBT, and a year afterwards, so they made sure they were really truly not treatment non-responders, they gave them either attention bias modification or just attention control test. And they found that both groups actually did similarly well, but they found that both groups did similarly well. And so what was encouraging is that this actually did help kids who did not otherwise respond to CBT. And it did raise the question of, well, is it really the bias modification or is it training that attention control? Regardless, we'll take what we can get, right? So that was kind of fun and exciting to see. One of my colleagues at McLean, Courtney Beard, is doing some really cool work with CBMI. So again, that interpretation bias. We talked about how sometimes with the kids, some of this stuff, the repetition just might be limiting. And so she's looking at it with parents who have the bias. And so she's running a pilot study. Some of our MAMP parents who were on the wait list participated in this. So again, this is an option for when you can't access care. Might there be this other intervention that you can engage in while you wait that might at least keep things moving along? And so I'm really excited and interested to see how this plays out as a potential other tool in our toolbox. Okay, so now to virtual reality. So this is the final little piece of the talk before we move on to questions and answers. So virtual reality has been studied in mainly in adult anxieties, in specific phobia, panic, and social anxiety, but it has some pretty good evidence showing that it can be really helpful. And so we in our clinic are really excited to think about how we could potentially integrate this with our own patients. It can enhance opportunities for inhibitory learning, which again, as we talked about earlier, that can really help not only with improving that early remission rate, but also helping with the staying power of the treatment. And it expands our exposure options, right? Like you can't just summon a thunderstorm out of nowhere, and but you can in virtual reality. Similarly, we can't go to each kid's school. I mean, some of our kids come to us from hours away, but you can in virtual reality. And so, and in COVID times, it's been really hard to find big crowds. And I don't know that our kids actually should be going into big crowds. And so this has been another way to really think about accessing that. And there's also this possibility of kind of an additional step. So we've got imaginal exposures, but oftentimes we can't, kids are not willing to go from imaginal to in vivo. So this is a potential kind of additional step to take before they get to that in vivo version. And so I wanted to show a couple of examples of what virtual reality could look like. So this is a study that looked at adolescent social anxiety disorder. And so you could see here that there's the social exposure party scene and the public speaking exposure. And so the authors of this study said that that this kind of suite of tool and videos would cost a clinic about $5,000 to implement. And then this is another one that that looks at public speaking in adolescents. So they did a school classroom setting. They also had a hallway and an empty classroom. So they had a couple of different options. And I don't know, they didn't mention how much it cost for the actual video production, but they did this using cardboard VR. And so that cardboard cost about $60. So virtual reality is actually getting more affordable. And so at MAMP, we were all set to go with a virtual reality pilot with a system that cost us about $2,000. And then COVID hit. So we had to change our plans because obviously we couldn't do virtual reality in person anymore. But the silver lining was that it actually forced us to have to look to see what else was out there. And we had to look for something that was affordable and that gave us remote access to video content. And so these three are example of VR headsets. But if you do an Amazon search, you'll come up with pages and pages of options. So this is by no means representative of what's out there. And so we started by ordering some versions of the cardboard. And what we found that was problematic was that the inability, so like the lenses are fixed, and so it really impacted the visual experience. And so the middle option is the one that we've gone with, because what you can actually do is you can adjust the distance in the lens, and that actually helps for the visual experience. And it's actually like a pretty tolerable. So you put the cell phone into that front pocket, just like that you do in that cardboard version of it. And to go along with our cheap headset plan, our very talented postdoc, Daniel Giddens-Stone, actually created a video library for us on YouTube. And so this is an example of an agoraphobia playlist where he just found a bunch of videos, and they're all free to access. And so as long as the patient has a smartphone, they can access these videos from home remotely. So I thought I'd try to bring this to life a little bit by talking through an example. We've used this cheap version of virtual reality now with many of our patients. What we found is that the patients and families are really excited to, because it's something new and something different, right? Again, we think about expanding our toolkit, and so it's not for everybody, but for some people, it's this very cool way to think about a different approach to exposure. And so we worked with a 17-year-old male, such a smart and talented kid. He'd been totally robbed by his anxiety. So even before COVID, he had enrolled in online learning due to his agoraphobia and social anxiety disorder. And so he came to us for help because he was starting to think about college, and he actually wanted to go to college. And he should go to college because that made sense for him. And so he really wanted to master this anxiety. When he came to us, he was only willing to go outside once a day to check the mail. That was it. And otherwise, he was completely sequestered at home. And so for the first 2 weeks of treatment, he basically continued to be willing only to maybe go out to his front door or his backyard, but would not do more than that. We maybe would do some kind of phone call social exposures, but we really hit a wall with him. And we tried everything in our armamentarium, from motivational skill and skills work, but the anxiety kept winning out. So finally we're like, oh, okay, we're gonna offer you VR. Let's try something different. And he was actually really willing to give it a try, right? Willingness for other exposures was like a 2 out of 10. Willingness to do the VR was a 6 out of 10. So we're like, okay, we'll take that. And so he engaged in a session of 45 minutes of a 45-minute session where it was about 30 minutes of exposure. And this is the cool thing, again, when we bring up inhibitory learning, we were able to give him kind of 6 different videos. So we were able to do different settings, kind of one after another. And we're able to kind of think through expectancy violation. What do you expect it's going to be? How is it afterwards? And then, so we made sure that we had some debriefing after the session. And so he went through kind of like he went through a grocery store, parking garage, park, we went through a very crowded fair that had a lot of loud noises. I wish I could show you the video, but my technology skills will limit that. But then finally, he ended on a college campus. He took a walking tour of it. He went into some buildings, and he experienced it virtually. And so to our great delight, the next day, he was actually willing to go to and drive to the college campus. We were shocked, but he said that the VR experience gave him the willingness to really face that fear. So he drove to the campus, drove around the campus, and on the way home, he felt so good about what he'd been able to do that he actually stopped by a local park and did a little extra exposure of walking around the park. So he's not cured by any means, but what's really cool was that this actually helped us move him along in his treatment. And so we're still very early course, but there are a lot of questions to answer, but this is a potential great tool to add to the toolbox. All right, so we're to the summary slide. So we know current best practices are effective, especially when you get them young, when there's low severity, and when there's good family functioning, but there are a lot of kids who need a lot more. But you know what? We've got a lot of different ways that we can optimize the things that we already have and add on to tackle this problem from some different angles. So I know this was a bit of a whirlwind tour, but I hope that I was able to inspire some thoughts for discussion, and really, really appreciate your attention. I'll close with one of my favorite Peanut sentiments, and I'm happy to talk through any questions that came up. All right, thanks.
Thank you so much, Mona. Really appreciate that. Now I'm having my divided attention task here looking at these comments. So I know before we get to questions, I know there's some questions. We're obviously behind time. What I want to do just to kind of get us back on track and sort of reorient everybody to where we are. Our initial plan had been to start with our panel at about 4 minutes ago. So what we're going to do is, and I hope Jamie Micko isn't going to kill me, but she's on mute, so I can do whatever I want. I'm going to give us about 5 minutes for questions with Dr. Patel, and then we'll go ahead and shift to the panel. So with that, there are a number of questions in the chat, which is just wonderful. Thank you to everybody. Obviously, we wouldn't have time to get to all of these in any event. But we will ask Dr. Patel to get us some answers to the ones that we don't get to today. As promised to Jennifer Lish, I'm going to start by asking our tech monitors to please unmute her, Jennifer Lish, to ask her question. Thank you. Jennifer, are you unmuted?
Hi, I was really intrigued by the stuff that you showed about yoga decreasing anxiety in teenagers. I've been very influenced by research primarily in adults showing that there's a dose-response relationship between number of minutes in the aerobic heart rate zone and decreasing depression severity. So I've been really pushing, and the dose response, there's a plateau at 150 minutes. So I've been super pushing aerobic exercise. Is the data as strong for any kind of resistance or strength or yoga exercise? Should I be pushing that too?
So I'll say that I'm not an expert in all of this data, and so it's possible that there is, but not to my knowledge. So when I did a search more recently, I did not find data that actually looked at it in that much detail, and so not to my knowledge. And especially in the exercise literature, they continue to just say stick with those general guidelines of exercising 60 minutes a day, but it's not very specific for kids and adolescents yet, to my knowledge.
Okay. Thank you so much.
But if anybody does know that, please feel free to email me, and I can try to email you with that response as well.
Thank you.
Thank you.
And then for our next question, I'm going to ask our crew to unmute Chrissy Camarada, please. I'm going to give it another second.
Are we looking at Chrissy with a K or Chrissy with a C?
Chrissy with a C, C-H-R-I-S-S-Y, Camarada. Is there a Chrissy with a K, Camarada? I love it.
She's unmuted. She'll have to unmute herself now.
Okay.
Can you hear me okay?
Yes.
Now we can, Chrissy, thanks.
Hi, good afternoon. This presentation was very informative. My question was just about accessing some of these internet-based CBT programs for just a general clinic setting. I know a lot of them are used in research, but are they available for people who work with outpatients in more general clinic settings?
Yeah, so the ones that I have looked at most, again, Sparks and the Cool Kids, and then the Cool Teens, and I've looked at Brave quite a bit. So Brave is in Australia only, not in the United States. And so again, this is one of those where I've not actually found one, but I do. So, and I don't think that the Kids Face Fear trial, I don't think the Cool Teens version is available to everybody. But again, if you want to email me, I'm happy to ask one of my resources who I've been talking with about this and see if there's anything additional out there that I'm missing.
Great, thank you so much.
Sure.
All right, I'm scrolling through the comments and the questions. I'm discovering a few things. Most horrifying to me is that I've been slipping in and out between calling you Dr. Potter and Dr. Patel, Mona, and I am so sorry.
No worries.
Late brain in the middle of COVID, hiding out in an office, hoping her 12-year-old doesn't come in. So my apologies.
I'm actually having the same worry. I realized that I didn't tell my kids that I'm off limits right now. I'm like, oh, you might get to meet my kids.
Yes, well,
totally get
everyone
it.
might get to everyone's kids these days.
Right?
So
How it goes.
So yes, my apologies, and I will mention that just by way of explanation, Mona's email is Mona Patel Potter, and so at least Mona, you've got your eyebrows. Am I?
Oh, you know what? That's the name that comes up. You're right. But my email is MP Potter. That was the only. Yes. No, you're right.
So my apology, only by way of explanation that my brain is about 60% gone, but not 100% yet. I'm holding on to that last 40%. And certainly
it's completely fine.
Now I'm just calling you Mona. Now we're gonna have we'll certainly be able to get you in touch with Mona and get her your email, get everybody her email as needed. So Mona, thank you so much. I am gonna end us here as we transition to our panel, and I'm gonna start by introducing Jamie Micco. She will be chairing our panel, and I'm going to ask her to introduce our esteemed guest. Dr. Micco is co-founder and managing partner at Concord Center. She's board certified in behavioral and cognitive psychology. She's a lecturer at Harvard Medical School and is the author of the Worry book for teens. Jamie, we are thrilled to have you here. The way that we're going to work this, and Jamie, please jump in and correct me if you want to do anything a little bit differently. We're going to have a Brady Bunch situation with lots of folks on the screen. Jamie is going to start us off with some questions to frame the discussion, and she and I will sort of go between posing questions to the panel. You all, as audience members, please do continue to go ahead and put questions in the chat box. If it's for a specific member of the panel, please go ahead and do that. Just specify who that's for. Otherwise, Jamie or I will either do my best to direct it or let Jamie do that. And we will see how this goes. So thank you and welcome to all of our panelists. And please, Jamie, over to you.
Absolutely. Thanks so much, Barbara. And thank you to the panelists for being here today. We will be presenting on the intersection of technology and youth anxiety. And I'm just going to share my screen for a moment if, Vicki, I can have permission for that. Okay. Thank you. Can everybody see that okay?
Yeah.
All right, great. So before we begin discussing our topic of the day, I want to go around and have each of the panelists introduce themselves, talk about some of the work that they're doing, and perhaps share some information about why this topic is particularly compelling. So I'm going to start with Ellie Leibowitz, if you wouldn't mind, Ellie, giving us an introduction.
Oh, hi, thanks for including me in this fantastic event. Those were two really amazing talks, and I learned a great deal from listening to both. So I'm Ellie Leibowitz. I'm at the Yale Child Study Center. I'm a psychologist by training, and my work focuses on child and adolescent anxiety, and in particular on family systems affected by child anxiety and parent-based interventions for child anxiety disorder, specifically SPACE, which is an entirely parent-based treatment for child anxiety. So that's a little bit, I guess, about me.
Great, fantastic, thank you. Next in the panel, we have Dr. Crystal Lewis.
Yes, hi, good afternoon. Yes, so thank you to both of our speakers. Those were wonderful presentations. I am a licensed clinical psychologist working at the National Institute of Mental Health. And currently I'm in Daniel Pine's lab on the section on development and affective neuroscience. And so ultimately our lab has ongoing pediatric anxiety studies, and we use a multi-method approach to data collection. So we collect neuroimaging data, behavioral tasks, we use psychophysiology, and essentially my role in the lab is providing the cognitive behavioral therapy to the kids who participate in our studies. And so I'm most interested in self-efficacy in youth and identifying moderators and mediators of treatment outcomes. So ways that we can enhance CBT, as we heard earlier on today, that we know CBT is effective, but there are a percentage of kids who don't respond to CBT, and the effects really want to focus on really remission rates. Yeah, and so today I'm interested in just hearing about everyone's perspectives on technology, and with everything going on right now, it's just important that we focus on ways that we can help kids using technology as well and see its impact on anxious youth.
Thank you very much, Crystal. Next on the panel is licensed social worker Lynn Lyons.
Hi, everybody. Thanks for having me. So I am a therapist. I'm in private practice. I also do a lot of speaking and training. I'm certainly, as a social worker by degree and by practice, I'm a very systems person. I work with families, in particular with anxiety, mostly with teens and adolescents, although I see a fair amount of adults as well. The focus of my work of late has really been working a lot with schools and able to come up with better plans for anxious kids. There's a lot of accommodating that goes on, unfortunately, in the absence of skill building. So I'm always trying to get in there and help people understand how accommodation actually doesn't serve the purpose long-term that we think it might serve with anxious kids. And I'm also very interested in prevention these days. What are the things we need to do, particularly if we've got families with anxious parents? How do we get in there as early as possible and sort of head off the generational transmission of this thing, and working really a lot with parents at being able to recognize their patterns, helping them focus on what we can do that actually makes it better versus the things that can actually enhance this generational pattern that we see so often.
Fantastic, thanks, Lynn. I keep toggling back and forth because I am not sure, is Dr. Walkup able to join us?
I'm
here.
Okay,
having
fantastic.
Trouble with his web camera, so okay. We will continue to work on that, but he is clearly available by audio.
Okay, awesome, as long as we can hear your voice. So next we have Dr. Walkup.
So you're having trouble with my web camera? Is it my camera or?
I'm not seeing your web camera right now, so I'm going to send you a chat with some additional directions.
Okay, I may
we
have
can
to
hear you, John. So
okay, all right. So John Walkup, I'm a child and adolescent psychiatrist and chair of the Pritzker Department of Psychiatry at Lurie Children's Hospital in Chicago. It's part of the Northwestern Feinberg School of Medicine. While I'm not a big fan of step care, and we can get into that later, I do think about technological strategies for delivering CBT are going to be absolutely critical in early stages of treatment, particularly prevention and preemption. So looking forward to kind of hearing today's discussion about how we can stage care for kids, and particularly if we start in pediatric primary care. I'm also interested in the presentation of anxiety somatic symptoms as they present in neurology, cardiology, gastroenterology, and a variety of the medical subspecialties in our pediatric hospital. So I think also internet-based interventions will be potent for that population of patients who really want to stick with their medical doctor and don't necessarily want to see a mental health person.
Thank you so much. And finally, I'm the fifth member of the panel. I'm Jamie Micco. As Barbara introduced my roles, I also am the chair of the ADAA Professional Education Committee. And as we were planning the forum this year, we were especially interested in talking about technology as it relates to kids and adolescents with anxiety, in part because if you work with kids and adolescents, not a day goes by that you don't have some mention of technology use in a session or in a discussion about ways in which they're interacting with their friends, or these days learning at school. So it intersects across so many different domains, and it can't help but affect kids and adolescents with anxiety, both for positive and, as we'll see, sometimes to their detriment. So I'm so excited that all of our panelists were able to join us today for this program, in addition to our fantastic speakers earlier. So the plan is I'm just going to set the stage for discussion. We'll start with some questions that the Education Committee had, and then we'll turn it over to the audience for some Q&A. So first, in thinking about technology and how it intersects with kids and adolescents who have anxiety, we thought about some of the downsides. So with the rise in technology use and all that entails, so computer use for school, smartphones and texting, social media, websites, gaming, photo editing, you name it. Alongside that, we've seen a concordant increase, a sharp increase in anxiety and related disorders in youth. So specifically, rates of depression in teens have increased from 8.7% to 13.2% from 2005 to 2017. And also across a very short period of time, about a 5-year period, anxiety disorders increased about 20%. So this increase has occurred over a relatively short period of time, such that competing explanations, such as diagnostic advancements, increased access to mental health care, unique school pressures, they seem less likely. And in fact, there is some evidence that social media and other technology have been found to be directly associated with higher levels of anxiety, depression, and poor body image. So why might that be? Well, some of the factors that we hypothesize, and that there's been some research to suggest might be true, is that first and foremost, devices or device use might interfere with sleep. So especially for teens who prefer to interact with friends after they finish their homework or after dinner or what have you, that amount of time of gaming or interaction might go on so long that they're not getting to sleep on time. There's some evidence that the blue light of devices might interfere in sleep as well. Second, there are a great deal, there's a lot of influence on body image and self-esteem. This has been particularly found for adolescent females, though it seems to cut across age range as well, in terms of having a negative effect as kids are more and more exposed to different types of photoshopped pictures on Instagram, etc. Next, use of technology may distract from important interactions or tasks. So if kids are constantly distracted by things that are on their tablets or their phones, they may not be doing important things like homework or having family time or exercising. Another potential downside are the ways in which kids are using their technology to communicate with their peers. So there's much less face-to-face interaction or conversation, and much more text conversation or like brief videos on Snapchat. And that loss of social cue, like being able to look at people's faces and listen to their tone of voice, can lead to a lot of conflict because of miscommunications. Next, we also noticed that for kids who've been born with complete access to technology and being able to interact with peers whenever they would like to, they essentially have constant contact. So they have little break from some of the social stressors that perhaps in previous generations we had more of an opportunity to have. And then finally, there are a few other factors that have been shown to be very significantly deleterious, like cyberbullying, gaming addiction for some kids, and in some instances, unsafe behavior online, like sexting, getting caught up in catfishing, or other online predators. But it's not all bad. So, and in fact, I was talking with one of my teenage patients the other day and mentioned that we were going to be having this panel, and she quickly mentioned how stressed she can feel by some of her interactions with technology, but she was quick to say, I hope you're also mentioning that we have a lot of chances to talk to our friends in good ways. Like, yeah, don't worry, we got it. So here are some of the benefits of technology. So first and foremost, we know that kids do have more opportunity to connect with peers, and they might even be connecting with peers they wouldn't have the opportunity to meet otherwise if not for the internet or social media. I think some kids, even in certain high schools, might cut across social groups and what have you to get to know their peers a little better. Technology also allows for a great deal of self-expression. And I love how I've seen in some of my patients that they've also used technology to advocate for valued causes. So texting, people to vote in the election that's coming up, or participating in environmental causes and raising money online. These are things that kids are able to do now. And to Mona's point earlier, technology has also allowed an increase in access to mental health services, support groups, and other social emotional activities. And similarly, mental health apps, either as self-help or in order to augment the therapy that they're receiving. And finally, technology has allowed access to information or ideas outside of one's own communities. This has been particularly helpful for marginalized communities. I can think of more than one patient who identifies as LGBTQ and has been able to meet other peers who have supported them in terms of them coming to their identities in ways that they didn't necessarily feel safe doing in their own communities. So it's given a lot of support and information to teens. So with that in mind, as setting us up for our discussion today, we developed some questions that we think are really timely given some of the use of technology that we're seeing in our practices and in research. So the first question I wanted to pose to the panel, and the way that we're going to do this is people who are interested in responding to the question will just raise their hand physically, unless it's specifically directed to a member of the panel. But anyway, to start, if people could speak to how might anxious youth interact differently with social media compared to non-anxious youth? Again, both for positive and potentially for negative reasons.
So
Lynn, go ahead.
Okay, so one of the things that I'll see with anxious clients, of course, and with anxious kids, is that it is rife for social comparison. And I think one of the things that I talk to parents and to kids a lot about is recognizing the difference between social connection and social comparison. That we like to think that when kids are online and they're conversing with other kids or on Snapchat and that kind of stuff, that it really is a place of connection. And I think oftentimes it's a place of comparison. And being able to help differentiate that for kids, I think is really important. We've got perfectionism that comes into play. And the other thing too that I was in another thing, so I wasn't able to hear all of the presentations. I came in later for Mona's presentation, is that I think that we really need to look at the use of technology in schools, because the parent portals, kids having access to their grades and every part of their grades, that parents and kids are getting notifications when the GPA drops 1/10 of a point. So that it's sort of what you were saying, Jamie, in terms of having constant contact. I think not only constant contact socially, but constant contact in that academic way. And certainly with so much remote learning going on now, but this was certainly happening before the pandemic, is constantly, parents and kids constantly focused on grades and when an assignment is put in and when a grade is put in, I think has caused an enormous amount of stress for kids, particularly teenagers, in dealing with all of the school interaction technologically.
Crystal, you had a point.
Yeah, I agree completely with that. And I think although there are similarities between anxious and non-anxious youth and their use of, we'll say, like social media and the effects, I think, what I see with a lot of the kids is essentially kids who have anxiety end up having a lower threshold for feeling overwhelmed by the content and the pressure, specifically talking about social media and the need to kind of keep in touch with their friends through texting and video chatting. So I think specifically now, without the in-person interactions, kids are relying more on their Snapchat and Instagram stories, their pictures and posts, what are the trending TikTok videos, and I think they get their news and information from social media. And so there's this pressure to stay up to date, which I'm finding in kids that I'm treating increases their anxiety and worry about just fitting in and staying relevant. And I think kids with anxiety may end up avoiding social media and using their phone and connecting with friends for this reason. And we know this occurs, like I said, in non-anxious youth as well. But with our kids who have anxiety, there tends to be a difficulty with shifting, right? And they're getting stuck, and that can essentially result in more checking behavior and overall distress. So I think there are advantages and disadvantages, but these are some of the things that come up, I think, with kids who have anxiety and their use of social media and what's been going on currently over these past 7 months with just the lack of in-person contact and the reliance on social media and technology.
Sure. John.
Great discussion. I think I'm a population health guy, so I think it's important to understand that 80% of kids are going to do well in this world, no matter kind of what the challenges and stressors are. About 20% of kids have mental health problems. About half of those get treatment. And a recent study by Baer et al. Suggests that only about 38% of people who get evidence-based treatment actually have clinically meaningful benefit. That means a lot of our anxious kids are exposed to the background anxiety provocations of this world. If you think about where we are today, most of the kids out there, that 80%, are having a normal anxious reaction to the uncertainty of COVID, the election, and a variety of other things. Those kids are going to probably handle all that stuff pretty well. It's those kids who aren't treated well or aren't getting any services at all that are really going to struggle, and they get lost. And I think the thing I worry about most is those kids, because they're alienated and isolated because of their disorder, they tend to go to places on the internet and get themselves lost in places that are damaging to them because they seek some kind of refuge. And in that kind of high refuge kind of place, there is some additional risk above and beyond. And so I worry about not so much social media per se, but about where people go who are at risk and getting themselves kind of caught in situations that are difficult. One clinical vignette, talking with kids who are well treated, they look at me like I'm nuts. I'm worried about internet and school and, the election and racism in America. And they say, I would have worried about it before, but because I've been in treatment, I'm in pretty good shape, and I kind of take that stuff in stride. So I think it's important to think about the untreated and those kids who are actually in a much better place, and what a typical healthy reaction would look like to all of this stuff.
Lynn, yeah.
Yeah, so John, I think that you make such a valid point. I was just meeting with a young person this week, and she's doing much better as she's gotten a little older. But even, pre-COVID, she was one of these kids that you're talking about that she was really having a difficult time making social connections, really feeling like she belonged to a group. And so as a 13-year-old, she was venturing into those places. She was sharing pictures and sharing information with 20-year-old men. And her parents were trying to be attentive to it, but of course she was able to usurp their efforts. And I think that as you talk about that, such an important point, that loneliness and isolation with these kids is just such a huge consequence to then what comes next. And we know that anxiety and depression, that's where the real risks occur, don't they? So I just think that's a wonderful point to bring up.
The one last point I'll make relevant to this question is anxious kids and teens, far more than non-anxious kids and teens who also do this, tend to perseverate and get stuck on the uncertainty that comes from the communication that they're having with their peers. So if someone doesn't respond to a text or responds very tersely or says something that's ambiguous, that uncertainty is so incredibly difficult to tolerate. And anxious and depressed kids tend to fill in the blanks and come up with the worst case scenarios in ways that are really unhelpful to them. And sometimes in certain situations, kids will then behave in ways that then make it harder for them to sustain relationships. So like doing a lot of reassurance seeking or checking around their interactions with their peers. That kind of gets annoying sometimes. So it's something that I notice I work on a lot with kids.
Yeah, they double down and they go deeper into it, and they don't find the reassurance and support there through that deeper involvement. They actually become annoying.
Right.
I can add one brief point. It's interesting. What you said, Jamie, sort of touches on or builds on one of the earlier talks that talked about cognitive biases and that filling in of the blanks with the worst possible scenario. But same talk also mentioned attention biases. And one thing that we know is that people who are anxious tend to gravitate to anxiety-provoking information. Our attention is captured by that power play when we are anxious. And another thing we know is that a lot of the suppliers of digital information have a business model that is set up explicitly around what will capture your attention, right? The entire business model for a company, like a Facebook or a YouTube or whatever, they're set up around, and it's not necessarily a malicious thing, but it is sometimes an irresponsible thing. And what it means is that if your attention is grabbed by things that make you feel bad, that feeds the algorithm in exactly the same way as if your attention were grabbed by something that makes you feel good. And so it's easy to get trapped into an endless cycle of negative information. I don't mean negative, I guess I mean information that makes you feel bad, essentially, so that you can really get trapped into it in a very powerful way.
Right. That makes a lot of sense.
That ability to make the internet and web-based social media attractive is just what our apps don't do. They're pretty boring. They're kind of conventional. They're very stock. And it's probably the reason why people don't engage them heavily and don't have a chance to benefit. So I think it's not so much our CBT model that we need to work on. It's really how do we make those apps really potent to engage people and grab them and pull them in. That for me is the science that I don't think we've quite figured out in the mental health side of this.
Right. So one more question before we turn it over to the audience for the panel. Have you been surprised by any positive outcomes associated with use of technology by anxious youth in particular?
I can point to one thing. We did a study a few years ago where we looked at use of social media in kids with social anxiety and kids with autism and kids with both. And the findings were sort of interesting to me in that for kids who had social anxiety, we saw mainly negative effects of the more use of the social media. And what it looked like the most is that this was serving as an alternative to actual real life engagement with human beings. And so instead of feeling bored or lonely because you're not seeing anybody, you feel stimulated and even have social interaction, but you don't have the challenges of dealing with human beings in the way you would. But for kids with autism who did not have social anxiety, we actually saw very positive effects. And it seemed for them to be a bridge to better engagement with in real life as well. So like a stepping stone on the way to actually engaging with people and functioning better in the real world. So in that sense, that was a positive outcome as well. So I just found that interesting when we saw that.
So Ellie, what is it? What you're saying is that sort of with social anxiety, they were using it as an avoidance technique, and with the kids on the spectrum, they were using it as sort of a training technique.
Yeah, I think that's the interpretation that made the most sense. I mean, if you are anxious, so much of the modern world is sort of set up to enable avoidance, right? You don't even need to get on the phone to order your food. You can have Uber Eats and drop it off at your door, and you don't need to and the delivery person, especially how contact, but even before, right? Like so much of a lot of technology is set up to actually facilitate avoidance, but for some kids, it does seem to also serve as a place to practice interaction, as a place to learn about social skills, as a place to practice the judgment, things like that may make your ability to engage in real world actually better.
I would guess that kids with autism stay on interactions longer on the web than they do in person. And so the practice effect would be much stronger simply because they don't get as repeatedly rejected, or if they do, they don't notice as quickly. And so they have lots of time for trial and error and learning and building capacity. Really interesting point.
One of the benefits that I've seen actually is that teenagers, and I've talked to several, we're doing the Zoom sessions, and one girl said to me, months into this, she said, all of my friends, when we're talking to each other, we're spending time planning the party that we're going to have when this is over. And the rule is that nobody's going to be allowed to bring their phones. So we're going to have a sleepover, and it's going to be a technology-free sleepover. I feel like in some ways they're actually recognizing, we've been telling this for a long time, so face-to-face interaction is really important. And they're actually recognizing that it really, after a while, is getting old. They're really missing being in person. And even kids going back to school are saying, oh my gosh, just even if I'm in school 2 days a week, I am so glad to be able to see my teachers and to see my friends. And so I think through all of this, they're really sort of getting the importance of being in the presence of other human beings, which is nice.
I think the other thing that's fun is everybody is appreciating how parents are addicted to social media and the web too.
Yeah.
And so the kids aren't the bad ones in the family who are locked down, but their parents got the same addiction. There's a reconciling, if you will,
Yes.
of all of that.
Or a reckoning.
To your point, Lynn, I think I've also noticed some of that coming together during this time. Like, so I'm thinking of a 15-year-old girl that I see who had done the same summer camp every year. And it was like a female empowerment sort of camp that she just loved, and she felt like it was so refreshing. And it was also technology free. But obviously this year she couldn't do it. And that camp did a beautiful job bringing the girls together on a weekly basis, something to look forward to every Friday evening to just kind of talk, connect, and yes, use technology because that's the only way. But it was something that she really derived a lot of benefit from and wouldn't have been able to do otherwise. So I think that was something that I noted as a positive.
And I've had a lot of discussions with the kids I see. One of the questions I've been asking a lot of my clients, I've been asking them, what are they proud of during all of this? And also, what have they discovered during all of this? And a lot of them have said that I've discovered that I'm getting tired of social media. The article that Jean Twenge had in the Atlantic a few weeks ago, where her data was showing that kids were less depressed in 2018 than they are in 2020 based on their self-reports, which was interesting and has been disputed, of course. But one of the things they said is that they're getting more sleep, which is interesting now that they're home, that they're spending less time on social media. They attributed their better mood to less time on social media and more time with family. So I think there's a lot of potential stuff for us to harvest in our conversations with kids, and of what they perhaps have discovered during this. Of course, it's not all or nothing, but what have you noticed about this? How do you know this, that it makes you feel? I think it just gives us some low-hanging fruit to grab onto, which we should take advantage of as clinicians.
Certainly, and I think, Lynn, with that, what with some of my families, with the parents who are home with their kids, they're able to, I'll say, monitor a little bit more. But what's happening is there's a lot more family time. A lot of parents are reporting with the stress the pleasure of being able to spend time with their teens and their young kids. And so they're structuring, I think, the technology use around everyone's home. So there's more monitoring. So in a lot of ways, I think that can be helpful to integrate, less use of technology when the kids are with their family, but then also for the teens who do want to engage with their friends. I think parents are better able to monitor that. So on one hand, I think this is it's a positive thing.
Yes,
I think it's also important to note that the dogs are less lonely.
Very
They have people around all the time. They're laying on your butt and they're sticking their nose in your laptop. And I'm telling you, the dogs are the real winner here with COVID-19.
And the cats are annoyed.
I have met a lot of pets now that everything is
so true.
Yeah.
Nice to see you.
Some of that turns into too much information, I think, when you see everything that's going on in the background with telemed anyway.
Although sometimes even that like sort of too much information tends to be useful.
Oh yeah, we hypothesized about it, and then you have real data.
There you go. So I'm going to turn us over to the audience so that we can get some audience questions, and we'll probably go a bit over today. We understand if you need to leave, but that's okay. But for those of you who are able to stay a little bit longer, we'll get some questions in. So I see Barbara back. Barbara, are you able to, do you want to moderate some of the questions there? Great.
Sure, I'll mention, so a couple of things, a couple of housekeeping things before we get started. Ellie, I'm sorry to put you on the hot seat. We're getting a lot of feedback from your mic. I don't know if it's possible to shift your audio or do earpods or anything. I'll leave it at that. So we have a lot of audience questions. And before we jump into that, just to mention, we can go a little bit longer today. We can certainly stay on until about 3:15. Obviously, anyone who needs to jump off, even 3:30 if you wanted, anybody who needs to jump off, of course, we understand. If audience members or anyone is going to have to jump off, I do want to just take a moment to remind everybody that ADAA has its annual convention. And I had the dates here somewhere. It will be all virtual this year for very obvious reasons. And it will be March 18th and 19th. So please do, if you've never been to an ADAA convention before and you've enjoyed today, just imagine what 2 or 3 days like that would be. We hope you'll check it out on adaa.org. Like I mentioned, it'll be all virtual this year, and that's March 18th and 19th. So shifting back to audience questions, we'll get through as much as we can. First question I'm going to raise from Lynn Sequeland. Sasha, can we unmute Lynn, please?
Hi, this is Lynn. I'm sure there's no correct answer to this, but I'm curious how the clinicians are discussing with families limiting social media in this current time.
So I think that is it's like getting kids to go to bed early. I think that's really difficult to do. What I've been doing with families is focusing on how structure and predictable routine is the antidote to fear and worry. And by developing a daily structure where social media or access to screens for fun or recreational purposes is punctuating the work of the day. So you work for a couple hours, you take a break, you do some social media, you work for a couple hours, you may do some chores around the house, you may do a family activity, then you use some social media, and beginning to build social media into the activities of the day rather than let it be the default activity is actually the way that kids get more engaged in their life, and they actually begin to shrink their involvement with social media more naturally rather than getting into the power struggle with parents about whether they should be on now or not.
I think similar. It's not a one size fits all question either. So I think, you know, some kids do actually quite a nice job of policing the amount of time that they spend on social media or other technology, and other kids can't get enough of it and will do it no matter what, to exclusion of all other activities. So in those cases where kids have a lot of trouble managing it, I agree with John, like finding ways to structure the time, whether it's, for example, earning time represented by poker chips or points, so that they can get a certain amount of time over the course of the day for completing homework or helping with chores or what have you, can be one useful way to do it for younger kids. And for teens, I know that there are some, maybe the rest of the panel knows more about this, but there are some clever programs or apps that help kids kind of gather amount of screen time for the day, as well as apps or technology that can kind of turn off their phones or minimize time spent on social media in other ways. But I think no matter what the plan is, it's so important to have those discussions proactively rather than reactively. So it's not like getting frustrated with your kid because they've spent too much time that particular day and be like, that's it, no phone for a week. Obviously that's not going to go over well and it's not realistic, but your kid's going to have a lot more buy-in if you sit down and say, listen, we've noticed that we're all spending too much time on our technology. I'd love to just sit down with you and have a discussion about what we can do to change that. And then you're more likely to have kids who follow that plan.
I had a great a family did this. I'll just tell this because it was so clever. This dad was so clever. So he had a high school student, and during the summer, the student had to be working on a project. There were things that he needed to do academically, and the mom kept telling me that he can't get out of bed. This has been an ongoing issue with this kid. It's just impossible for him to wake up early. He can't get up until noon. Maybe there's something wrong. I don't know if he's depressed. So the dad, who is a very sort of analytical engineer thinking, said, okay, so here's what I'm going to do. When you get up in the morning, you can then get online, because he was playing a lot of video games. You can get online 7 hours after you wake up in the morning. So if you wake up at 12, you can get on, and he was able to control the internet. You can get up if you get up at noon, you can get on at 7. This kid got up at 8:30 every morning and did his work that he needed to do, so that then he could get up so that he could get online at 3:30. I thought it was just brilliant. The mom was so concerned he didn't have this skill. Dad said, yeah, here's how it's going to go. And boy, that kid rose to the occasion. So sometimes a little creativity, and I didn't come up with that plan, he did. But sometimes just saying to parents, let's figure this out, or saying to kids, let's be a little creative. I just thought it was brilliant. Yeah.
That is brilliant. Let's shift over to Wilson Jacobs. Can we unmute Wilson?
Hi, hello.
Hi, Wilson. Go ahead.
Thank you guys for putting on such a great and informative panel. Yeah, I have a question about really the detection and diagnoses. What are some of the tools that are used by schools right now to detect if a kid has anxiety or depression? And then what are some of the hurdles to improve like a greater amount of diagnoses than we have?
Well, I can just talk to some of the schools that I work with. So there are certain screening tools they're using, and they're pretty simple. And I'm forgetting the name of so if somebody else knows, you can jump in, but very simple, sort of similar to the ones that we give kids when they go into the pediatrician's office or go into their doctor's office. So just a list of questions. And it's there, some of them, they call it mood monitoring. One of the issues that's come up with in schools is that then what do they do if a kid comes in and fills this out and there's something that needs to be addressed? Then what's the next step? And so how do we deal with kids that become sort of flagged in this? And schools are really struggling with that. There are a few pilot programs that are happening. And it sort of goes back to what Mona was talking about too, where they are providing therapy to kids during the school day, and that therapists from different places, if you sign into this program, And then the kids are having their therapy session. There's a separate room where they attend the therapy session. There's somebody there that sort of monitors it. They don't have to leave school. It's free of charge. It doesn't require parents to take them to or from their appointments. It's great for areas where there's not a lot of accessibility, rural areas. So they're trying to work with it that way. I think one of the biggest issues in schools right now that I hear, and this is both in public and private schools, is that we are not a therapeutic boarding school, or we are not a therapeutic school. And they really don't know, you know, they're getting bombarded. They get letters from therapists, they get letters from physicians of all the things they're supposed to do, and they really don't know what to do is the answer. So there's a real interesting sort of gap or challenge, I think, for schools to be able to figure out what their role is in the mental health of the students. If you're going to give them these screenings, then what do you do next? And I think that's, unfortunately, there's a bit of a chasm there that I think they're still trying to address.
That many of you will remember the period of time when Teen Screen was popular for teen depression, and how over a period of time there was a fair amount of backlash, not just from teachers but from families that really didn't want their children probed in that kind of mental health way. And it may not have been for good reasons, but and I think it's important to understand that that shift went from an emphasis on screening in schools to screening within pediatric primary care, where everybody goes and they trust the provider and they see mental health as the kind of important component of that pediatrician or pediatric provider's role. So, and there's lots going on in primary care in terms of screening. Great strategies, and people are picking it up. The American Academy of Pediatrics is pushing it very, very hard that kids should be screened for autism, ADHD, depression, and late to the game, anxiety, even though it's probably the biggest driver in prepubertal kids of internalizing conditions. So,
yeah. Ellie, did you have a point?
Well, I guess I have a slightly more pessimistic view of the current state of affairs, which is that the problem is not how do you screen, right? That's the easy part. It's not hard to detect anxiety, and there are really brief screeners. There's 5-question screeners, like the mini scared screener. It's not that hard, but the truth of the matter is, at least in my experience working with a lot of schools, and the same for primary care, there are many schools and there are many primary care providers who are doing no screening for this at all whatsoever. And yeah, the American Academy is definitely pushing for it, but most pediatricians today, based on surveys that the Academy has done, they've gone from a very low rate of like confidence in can I detect and address like ADHD. That has increased tremendously over the past couple of decades. It's really gone up tremendously. Anxiety, not really, not so much. And I take my kids to the pediatrician every year, and every year they ask me if my kids know how to swim. But in Connecticut, you have to ask if they know how to swim. But they don't actually ask about anxiety, and they don't actually ask about mood. And so I think we should be doing more, because it's such a missed opportunity to not be screening for these, for these problems. Then you get to the point where the only kids who are detected, or the kids who are detected, are often the ones where it really is only a case for tertiary care and much more intensive care. So there's a huge missed opportunity, even if things, maybe are not quite as bad as I'm making them out to be, but they're not that great either.
Yeah, if I had my wish, pediatric primary care doctors would do a family history at the first well baby visit and begin to do anticipatory guidance around ADHD, anxiety, and depression, with parent training for ADHD, a fearless family for anxiety, and behavioral activation for those family histories with depression. And if they started that at day 0, we would have a bunch of the complications of some of those conditions mitigated simply because it was addressed very early through anticipatory guidance.
Yeah, I think that's what I'm really focusing on, John, now with my work, is how do we, because we know how predictive family history is that how do we educate parents about this? So, and how do how do we empower them so that they pay attention to their patterns, that we give them the tools and the skills that they need? I think it's such a missed opportunity. It breaks my heart when I've got a family that calls and they've got a 17-year-old and is trying to get them off to college. And I take some history and they say, well, he's been anxious since he was 4. Right. And but nobody's given this family, or the family hasn't reached out for any guidance. I really think that we can get ahead of these things because, you know, as all of us know, once you learn about it, once you know about it, it's not that complicated to teach these skills to parents if we can do it in a very deliberate and very supportive way.
It's interesting because I've definitely seen more in the way of integrated mental health care at primary care, but I have to be 100% honest. Oftentimes the people that are providing that care don't have training in empirically supported treatment for kids, or even for parents with anxiety or depression. So they may be catching it, but then it's not really going anywhere. And then ultimately the same pattern happens where they end up in our office because they need this high level of specialty anxiety or depression treatment or ADHD.
The AAP is coming out with new training guidelines that essentially say that pediatric residents have to be trained in behavioral health. But it's the same kind of problem as with teachers. Teachers want to teach, they don't want to be therapists. And pediatricians want to be pediatricians, they don't want to be psychiatrists. They just realize very shortly that they have a huge behavioral health burden that they have to take on. And for some of them, it is natural and they pick it up really quickly. And then for others, it is just a completely different worldview. And they're not going to be able to be early adopters of this whole process.
John, wouldn't you think, though, that in that sort of a model, embedding, you know, the PTBH model, right, embedding the mental health folks in that pediatric practice who do have, you know, to Jamie's point, the evidence base, the skills to address that, right? I think there are two challenges, and I'd love to see us address both, right? One, to your point, that pediatricians don't want to be psychiatrists or psychologists or social workers, and the second, who in mental health, who does want to do those things, who is embedded in the pediatric practice, what's their training, what's their knowledge base of scientifically sound interventions?
Yeah, I think there's a couple of issues. We've chosen not to embed because we have we have a large number of small pediatric practices that don't have office space. So what we've done is we've developed collaboratives, psychotherapy collaboratives and pharmacotherapy backup for the pediatricians. And so when kids screen positive, we hook them up by zip code with evidence-based practitioners. And so we have it, but it's not embedded in quite the same way. The other thing that we've seen is that if you were just to survey your community and look up psychotherapists and went to their website, you probably wouldn't see many who would advertise themselves as doing evidence-based practice. People do a lot of things in the therapy environment, but they don't do a lot of evidence-based practice.
We ready to shift? Can we unmute? Yeah, thanks. Can we unmute Jennifer Lish? She has a clinical question.
Hi, I have a lot of teens whose school is completely virtual or hybrid virtual, all but a couple days a week, as well as a lot of college age youth who've deferred a year because of COVID. So a lot of young people living in their parents' homes who are exhibiting, you know, sort of the vampire lifestyle, up all night on a Discord and playing video games. I have one that has 30,000 followers on TikTok, but when she went to college, she stayed in her room, couldn't bring herself to join any club, didn't go to classes, didn't go to the cafeteria. So advice for parents and for the youth who are dealing with this, maybe call it delayed sleep phase syndrome, not engaged, sleeping all day. Do the panelists have any advice? especially Eli Leibowitz.
But no presents. You know, I have a device in my house, and there's no conflict of interest. I don't have stock in the company, but it costs $100, and it's called Circle.
Yeah,
And
it's a good one.
it's a fantastic device because what it does basically is scan your network, and it recognizes all the devices that are using your internet at home, and then you can assign them to people. Like, this is dad's phone, this is mom's phone, this is kid's iPad, this is sister's laptop. And then at any moment with an app on your phone, with one tap, you can turn off all the devices that are belonging to this person or to that person, or you can set a schedule that says all the devices go off, all these devices go off at this hour, or what have you. Basically, what I think is that you can't really have something in your house that can be damaging and that you have no control over. So that's maybe a big statement, but that's the way I approach it. If I'm going to have this in my house, I'm paying for it, and then I have to be able to have some degree of control over it, or else it just makes no sense to me. So whether you use a device like that, or you set up a system that says on a day in which you didn't get up before X time and weren't able to do the things that you were supposed to do, maybe the following day it's just off completely for 24 hours, then we try again. Mm-hmm. But these are not easy answers, but they are doable answers, because I've done it myself and seen it and done it with many families, time and again. What you need is commitment to do it, and what you need is a way to do it that is not going to trigger World War III in your house. And so I never recommend coming to a kid and grabbing the phone out of their hand, or shutting off the game that they're playing in the middle of when they're playing it, because these things trigger high-level, high-affect conflict and escalation in a way that is counterproductive and that you're not going to want to do regularly, which is why I'm suggesting these alternatives that don't require you to have that moment of conflict and escalation. But one way or another, I think there has to be some degree of control over this if you're going to be supplying it in your house.
Ellie, Andrea, Brandon, and I would like to confirm the name of that device. I don't know why she wants it, but I'll tell you, I don't see kids, so did you say it's called Circle?
It is called Circle. It's actually made or sold or whatever by the Disney company, the Mickey Mouse people. So I don't know exactly why, but I think the website is like mycircle.com or something like that. But if you just Google like Circle and Wi-Fi or something, you will find it easily, and it works well.
Andrea would like to confirm that she does see children clinically. I do not, but I like the sound of that.
I think it's a little bit important to point out that some families have never really had to run their shop. And now that their kids are home and the internet is default for all activity for themselves as well as their kids, they have to not only kind of get control of their access to screens, but they have to get control of their family again. And so I think sometimes when they ask us a question about screens, we got to go to the cause of the problem. And the cause is that they've never really been able to run their family effectively. And they need to kind of go back to basic parenting principles, reestablish a sense of order within the home. And I think in that context, they'll see some ability to get control of some of those things that stick out or appear on the surface to be the kind of core problem.
I've seen some kids, unfortunately, get around the Circle in various ways, and despite it being an amazing device. And I think, so I have 2 points. One, especially for kids who are just like coming to be using their phones or video game systems, I'm a big fan of just like setting up a basic contract to start. And again, like, this is the agreement. This is what will happen if you break the agreement, and there will be a device vacation if you are not able to meet the requirements here, so that there are no surprises. But I also think Jennifer was getting to the point of like college students being home, and I think it's a lot harder to police so-called adults.
I have one in my house, so I'm just gonna say amen to that. Yeah.
So I think, I think that part
He's
of what
22.
amazing. I think part of it that we need to think about is both validating this experience of like being home and like you don't want to be at home, you want to be at school or like living in an apartment or what have you. And so this is a really hard time. And if your friends are staying up all night, then I get that you would want to do that too. But then second, we have to use our best motivational enhancement skills and talk about reasons why, what might be in it for them. What are the pros and cons of continuing to live the nocturnal lifestyle? And so on and so forth, to help them be able to come up with their own traction to make change in this regard. So those are my
one of the things that's happened in my house is my son is home and he's got many friends from college that are in different time zones. And so when he is participating with them, he's on East Coast time, they're on West Coast time. And we've had lots of conversations. And to me, I think what I focused on and what I focused on with my clients talking about it as well, is that it's also just a matter of courtesy in a family. Is that there are certain obligations that you have and there are certain things that you need to do. And if I'm going to bed at 10 o'clock, then I don't expect you to be up at 4 o'clock. And if we're getting up in the morning and you're getting up at 2. So it really is, again, just sort of thinking about how are we going to work as a family in this way that maybe we didn't for a few years, but going back and setting those boundaries. I also have found that where parents are really good setting boundaries in other things, they're lousy with technology. So they'd never let their kids go up in their room and do a bong hit after dinner, but they'll let them have their phones in their room until 3 in the morning. That it's almost like they're really good at setting limits, but there's this technology blind spot. And I've talked to a lot of family members about that too.
Yeah, I think that's a good point, Lynn. And John mentioned earlier, just in terms of families kind of now or parents taking control of their households, what we've seen a lot of is parents not even thinking to limit screen time and technology use. Right. And this goes back to Lynn's question of how do we have these conversations with the parents to limit the use of the technology and not just social media, but the technology. A lot of the kids will say, well, I need it for school. I'm up late, doing work. And so I think it's just these conversations around being respectful in the household, having schedules, right, and structure to when we will use the technology. I love the idea of using something like Circle to kind of see, who's up and who's using the technology. But I think it is tricky. It is hard, and it's going to take time for families to adjust, and it has to work through like how do we set these goals at home for our kids, our older kids, our college students who are home. And then for us too, if we are working with any of the college students, I've used, Jamie, some of those motivational kind of interviewing questions with them in terms of, okay, well, how do we help them push past this ambivalence about wanting to change this behavior and really just helping the family that way.
So I think what I'll do on that note, because I think it's a wise and important note to end on, I will go ahead and end us today with a couple of comments. First of all, and most importantly, thank you all. Thank you to all of our panelists. It's so wonderful to have so many people with different experiences and broad experiences on our panel. Thank you, obviously, to our speakers, to our attendees. We had over 100 people with us today, which is really wonderful. And of course, to ADAA for hosting this, and to ADAA for the technology. I see people are vanishing. I assume that's happening on purpose. I'm just going to keep talking. Lynn, it's just you and me. Now it's just me. So I do want to thank everybody for that. Another reminder, I know we have a lot of folks on who may or may not be ADAA members, may or may not have ever attended our conference. But we do have a fully virtual conference this year, March 18th and 19th. The topic, as you can see, is on resilience and recovery from research to practice. I know for myself, it's been a great year to try different conferences I don't usually go to because they've all been virtual. So if you're interested in that, certainly please do take a look, and we hope to see you there. In terms of leftover questions or slides, etc., we will take a look at the chat. We will do our very best to address all of those and get you the information you would like. And that is it for our second annual Fall Forum. Thank you all so much for being here. We really appreciate it. Be well.
Thank you, Dr. Pam Hulse. If you are not yet an ADAA member, we invite you to view
Thank
the many
you.
membership benefits that ADAA has to offer, including year-long access to continuing education webinars, access to special interest groups, including online peer consultation groups, promotion of your practice in ADAA's online Find a Therapist database, significant discounts to ADAA's annual conference, website listings of your clinical trials, support groups and publications, and much more. Please visit adaa.org to learn more. On behalf of all of ADAA and all of our presenters, we thank you for joining us today.